Yeah, Ahilasamy, you can carry on.
Good evening, dear friends, and good evening, all the attendees who are watching this program. Is my voice okay?
Ahila is
Hello?
perfect. Perfect, Ahila.
Voice okay. Can you see my screen?
Yes, I can see your screen. I can hear you very well. Carry on.
Okay. So I am going to speak on my innovations in endoscopic ear surgery. Before going into the program, let me speak a few words. Already, my dear friend Janaki, I used to call his Janaki, and has told a lot about all three of us. And I don't call him Janaki Raman, I call him Janaki, and my mother's name is also Janaki. So whenever I speak to my mom about Janaki Ram, she used to tell, did you tell him that my mom's name is Janaki, like that? Okay, fine. And we all did post-graduation together. That time was a golden era. People used to say like a golden era. It was a golden era. We had a great time. We were all tough. We were brave. We were fighting like anything and beating, and we are tiresome in working round the clock in the wards and OPDs in the theater and studying and creating knowledge and everything. And myself, Janaki, Vetrivel belong to the same batch of MS post-graduation. Dr. Andy
Ahilasamy, we can't hear you.
Can you hear? Can you hear me now?
Better. Yeah. Carry on.
Okay. So Dr. Anthony was also in my same unit, and we had a great time. And daily he used to fire me like hell. Even though we are co-PGs, he fires, and the way he shouts at me, that the door of the wards will be fluttering that amount. So, but still we are all thick, great friends, and that hard work we put in our post-graduation days brought us to here. Okay. Before I start my innovations, my good friend Dr. Janaki used to tell me always don't go to leaders, always go to innovators. So I say that you go to leaders with innovations. So that created me. Let me. So before I go into the program, I thank my Johnny Ram for moderating and arranging the program along with Alembic and arranging this webinar. I am living in Chennai, but I am native of southernmost tip of India. That's called Kanyakumari district, and beautiful beaches, and that's my native place. Lot of beaches and everything. Okay, these two are the big corporate hospitals where I operate. Okay, let me play this video. Okay, before going into the video, let me tell. Myself, Janaki, we got into post-graduation MS in the year 1995, and we finished in 1998. From 98 to 2006, I was working with K.K. Ramalingam's Ear Institute, and 8 years I was a rhinologist, pure rhinologist. I never touched the ears. When I came after that, 2006, I didn't have much hands-on here, but I had a will that I want to do here. So next 2 years, my life was moderate from 2006 to 2008, and I had an will to do something great. I want to impress, I want to innovate, and I had there was a fire under the belly. So in 2008, 2009, I kept on watching this video advertisement in between every over of the cricket match. You can see this video. This advertisement changed my life. Hello? Can you hear me?
Yes, I can hear you. Did the video have also voice? Because we didn't have any background from the video, just the video played.
Okay, it had voice, but I don't know, the volume was less maybe.
Okay.
One second. Let me check whether this is any muting. Once again, I play. Sorry.
No, the voice is not coming. There is no voice.
Harsha, are you getting the voice? Harsha? Harsha, Anthony? Are you getting the voice?
No, Ahila, voice is not coming.
Okay, fine. Forget it. Okay. The thing is, Dhoni was telling, if you want to be successful, you have to be different. You have to be different. Let me explain. That's a final of the World Cup 2007. So everybody were thinking that he will be giving the ball to Harbhajan Singh for the final over. But Dhoni was telling, I had my own ideas, and he gave the ball to who is that? Somebody else, a new bowler, and he got the one. So if you want to be successful, you have to be different. So I thought I had to be different from others with innovation and everything that. So I want to claim like this, but at least I have claimed like this. Okay, endoscopic ear surgery. It is an evolving art. It needs constant improvisation, instrumentation, visualization, and illumination. A clear bloodless field and good post-operative healing and new cosmetic and functional results than the microscopic method. So that's the hour of the need. So I concentrated on this part of the endoscopic ear surgery to do something different, something new, so that I can achieve something different. I want to be different from others. So watch this video. The nightmare in temperament is the bleeding. It's a narrow ear canal. It is a endoscopic transcanal stapes surgery done under local anesthesia. You can see the amount of bleeding even while elevating the tympanomeatal flap. This is the reason why many youngsters doesn't take endoscopy ear surgery because of the bleeding and everything, and people were thinking of going to two-hand and everything. So I to get rid of this fear and everything, to overcome this difficulty, I invented this Ahilasamy diathermy round knife, which I will show the assembly. This is a Rosen's knife with the insulation, and it has a monopolar cable. And it is a fusion of usual diathermy knife in our operation theater with the Rosen knife. When I combine together, I got it this like this. Let me play a small video. This is the freshening of the edges of the tympanic membrane perforation. So I am using my innovative knife. That's a round knife which has been insulated, and use the power as very low as possible, 10 watts, and ask the nurse to suck the fumes. Many people advise me to have a suction. If I have a suction along with that, then the steadiness of the instrument will not be that good. You see the elevation of the tympanomeatal flap, hardly any bleeding. It's almost like a cadaveric field, and when you are having a field like this, there is no need for two hands or any difficulty. This is my innovation, and there was a lot of objections to that. It does everything absolutely no, it heals absolutely brilliant. There were papers, people using monopolar diathermy within the middle ear and etc. by Italian, French papers and everything. That gave me an idea. Without those things doesn't cause any sensory neural deafness and everything. that gave me more additional vision to do this, innovate this knife. So this has been published as a paper, and it has been patented, and this is a patent number. And if you go to Google, you can search the knife, you can get it, and it is being sold in the exhibition stalls in the conferences. Why we need this? Ahilas directed me round knife, safe, fast, and more efficient in maintaining the hemostasis while elevating the tymphanomeatal flap, simultaneously elevating the tymphanomeatal flap without using the suction. Always, this is a monopolar cable instrument and ear canal instrument with a low power. Always use low power, diathermy setting at 10 watts. You keep an external suction to suck the fumes. Lot of criticism while I was innovating this instrument and introducing this instrument. It will burn the ear canal skin. It will cause nerve deafness and everything. But I was very focused like this, and I implemented, I innovated, I patented, and I published. And it is selling like anything. One more small video clip I am showing. This audio, can you hear? No. This audio, can you hear?
No, we can't hear.
Okay, fine. There is something wrong with the audio. No problem. Let me explain. Okay. This is a Rosen's knife connected with the monopolar cable. Same thing, make the canal incision. Yesterday, I was watching Professor Prosciutti, Italian, who is something like the father of endoscopic surgery, having a Colorado-like knife, making incision. But without knife, you can make incision. But with my knife, you can make incision. Along with that, you can elevate the tymphanomeatal flap. That's the biggest advantage. And if I keep a suction inside, if there is a suction, the instrument will be hollow and it will not be sturdy. So I have a suction outside to suck the fumes. And if you have a suction also, that charring material will go and block the suction port. So this is mostly always bleeding up from the incision site in tymphanomeatal flap elevation. This is the luxury of having this knife. And it has one more use. You can use it for septoplasty as well as making incision. This is a septoplasty infiltration on the left side. I am making the incision on the left side on the convex surface of the septum. Little fast forwarding the video. Patient done under local anesthesia, under normotensive BP, hardly any bleeding. The advantage is whenever you introduce a scope into the tunnel, every time it doesn't fog because there is hardly any bleeding from the incision site. This is one more additional advantage of the instrument. And the fogging of this telescope will not be that much when you have an incision site made with this knife. Okay, so sterilization, it is like any other instrument. I don't want to go into much detail. You can put it in the tip of the instrument into the side X, and the cable, you can have a gas sterilization or a formalin sterilization, etc. So no, there is no need to use a two hand for the surgery. You can do very well, elevate the tymphanomeatal flap with a single hand. It is something like a game changer. It reduces the surgical time. This is a paper which I have published in the Indian Journal way back 2 years ago. These are some of the publications quoting the use of the monopolar diathermy knife in the middle ear. So take home message is, it's a game changer in endoscopic ear surgery, clean incision and bloodless field to operate several other applications in the surgeries also. Okay. So there is always a fight between that. You cannot do a good surgery with a single hand. You require a two hand. So that problem I can manage. So you don't require a two hand. You can do with single hand itself. And one other of my innovation, I will show it little later. And again, there is always a fight between the endoscopic and microscopic ear surgeons. It made my innovations as a cosmetic endoscopic ear surgeon, so that I can convince my patient that I can do a better cosmetic endoscopic ear surgery, giving a similar result to like the microscopic surgery. That is the endoscopic scarless tympanoplasty and mastectomy using homograft septal cartilage. So I do all type of tympanoplasty, central perforations, osculoplasties, post-retraction pocket, cholesteatomas, even involving attic antrum and mastoids. So most of the cholesteatomas, everything, if I start with the endoscope, I finish even if it goes up to mastoid or middle ear, epitympanic and protympanum, everything I do with endoscope itself. But if I have think that there is some complications with the cholesteatoma, everything, then I start right away with a microscope. So I don't shuffle between the endoscope and microscope, in between everything. The planning of surgery is very, very important. If I start with endoscope, I finish the whole surgery wherever it has involved with the endoscope itself. This is some of my experience of tympanoplasties over the past 8 years, and mastoids I'm using with the septal cartilage scarless for the past 5 years. See, the advantage is no scar, easy to convince the patient, abundant material available, no reaction, no necrosis, but I will give the antibiotics to the patients post-operatively. That is always must. So you cannot really say that no. It is easy, cheaper, faster, because you save the time of taking the harvesting the graft material, everything, and post-oral incision, everything. You are saving time. Easy to revise, less instruments because you don't graft material. Autograft temporalis fascia or tragal cartilage, and you can easily do it under local anesthesia. These are the septal cartilages from the previous septoplasties. I harvest and preserve it in 70% alcohol. That is, if it is 7 ml of rectified spirit, 95% spirit, in which I add 3 ml of distilled water. And we keep it for 3 months. Once in 3 months, we change the solution alone. And you can keep it for any longer period. Nothing happens. No reaction, nothing. So a lot of controversies, people objected to using this homograft septal cartilage because it produces slow virus disease, etc. Because I had to nullify everything. I had to fight like a Baludeva against people who were against my views, and overcome that and publish this as a scientific thing. This is as a septal cartilage. You can slice it. I will show it with a video. You can slice it with a cartilage slicer. Or you can use a blade with a slice, or you can use a 22 blade also to slice the cartilage. And for mastered reconstruction, everything, I don't use the sliced cartilage. But in my experience, slicing of the cartilage helps in easy insertion of the cartilage, but results doesn't vary much. So next, come to the CSOM with central perforation. I will play 2 videos. This is a video with temporalis fascia, which is not part of my talk today. You can simultaneously watch, but this is the video where I will show you the central perforation manage. The edges of the perforation has been freshened. I am making the canal incision with my knife, Ahilasamy diathermy round knife. And I will be using the cartilage graft. Harsha, Janaki,
Yes, yes, we can see it and hear you.
video is okay?
Very clear.
My voice is okay?
Very clear.
Okay, okay.
Professor Majumdar sir is watching you.
Oh, thank you, thank you, thank you. So I have elevated the tympanum metal flap. You can see it's a very short video, highly edited video. Then the septal cartilage, which has been preserved in 70% alcohol, I am using it as an always under like an underlay graft. For all these cartilage immunoplasties, we use as an underlay graft. For comparison, I am showing it temporalis fascia this side. You can, if there is some gap or something, you can adjust the cartilage. Yes, like that. Remember, it heals beautifully. No stitch, no scar. Totally scarless surgery. Only totally scarless tympanoplasties. Even if you use tragal cartilage, there is a small scar on it. So let me play a couple of videos. This one with a very thin sliced cartilage. This one without sliced cartilage. This video I'll be showing this patient as an incus necrosis. So I'll be using an cartilage from the septum, that is homologous septal cartilage, as osculoplasty also. You can see very sliced thin cartilage using as graft. This is with a Strauss camera. This is with a Stryker camera. You can see the color difference between Strauss and Stryker. This is not a sliced cartilage, little thicker, but inserting is little difficult, but the post-op results are similar. But if our, yes, that's the thing. Cartilage, now I will be going for the osculoplasty on this side. For thinner grafts, I keep gel forms in the middle ear to support the cartilage, like how you support the temporalis fascia. So after putting the cartilage, I am lifting and I will be keeping a vertical strut, like a type 3 menoplasty, cartilage strut under the graft. Here you can see this just keeping the
video is not playing.
cartilage. Hello?
Yeah. Now it's playing.
So this side I have kept this vertical strut. You can see cartilage, that also septal cartilage. Then I will put back the septal cartilage as a like the.
Ahilasamy, your video is not playing. It's getting stuck up.
Okay, these videos are quite high quality videos. Is it playing right now?
Yes, now it's playing.
Okay, it's finished. Let me move on. So these are post-operative. This is post-operative 3 months. This is post-operative on the 21st day. Post-operative 21st day, you can see I have removed the crust, so you can see the bleeding points. This is the right ear. On the 21st day, you can see the audiogram, hardly 10 decibel earbone gap with cartilage. This is another video. This is 3 months post-operative. This is a pre-operative audiogram, and this is a post-operative audiogram, around 10 decibel earbone gap. This is another video I'll play. This is on the 21st post-operative day. It's a drum. This is done with my diathermy knife. So there is some crusting. There will be thing. This is without. It's an old video without diathermy knife. So there will be less crusting at the incision site. Yeah, always with the diathermy knife, there will be slight crusting and everything. But that's acceptable. It takes a couple of few days more to heal. Janaki, you want to interrupt and ask any questions, or shall I proceed?
Now, I think you can proceed. We will take the questions at the end of the lecture.
Okay, okay. So if these people come to the patients, then it's easy to and do grafting. But if they come to me as Neymar or Hardik Pandya, or this picture I took it from Chennai airport, even now ladies have hair like this. They won't allow to take a temporalis fascia. They won't like to have a scar. For these things, the scarless will be definitely a solution. Then people will be asked, why don't you use a tragal cartilage? So this patient will definitely cannot take a tragal cartilage. This patient you cannot take a tragal cartilage. This is one of my friend from Chhattisgarh. She is an ENT doctor. This is her tragus. You can't take obviously take a tragal cartilage. So, and if you take a tragal cartilage, then this earphone plugs will not fit so tightly. So the thing is cartilage, homograft septal cartilage superior to temporalis fascia? But definitely an alternative. That's my answer. These are various articles of preserved septal cartilage used for rhinoplasties and for osculoplasties. And there are articles that have been published of tragal cartilage for tympanoplasty. So I combine both cartilage for tympanoplasty and preserved septal cartilage for rhinoplasty, osculoplasty. Professor Magadeva was using it for the past 50 years. Both together I put it and made it this. So this article I have published some 5 years back in Indian Journal of Otorhinolaryngology, endoscopic tympanoplasty using nasal septal cartilage as allograft. And my article has been even cited. There's a citation by the Japanese people. So now come to the tuberculopneumotic disease, that is cholesteatoma. So I will be playing a couple of videos. As I told already, I do most of this is a right-sided cholesteatoma, attic cholesteatoma, attic perforation. I do most of the unsafe years by endoscopic method itself. If I start with endoscope, I will finish it with endoscope itself. I don't jump microscope and endoscope. But if I previously itself, I know that it is quite extensive or there is complication, then I go for microscopy. So this is the elevation of the tympanomeatal flap on the right side. So with the endoscopic mastectomy, you can even preserve the chorda, which you cannot preserve in the this eroded incus. I am taking it out. This is a cholesteatoma. So with the one hand itself, you can do a good job. But if you require two hands, you can ask the assisting nurse to suck or hold the scope, and you can manage. So here I am drilling and holding the endoscope. My assisting nurse is holding the suction. This is sometimes, many times I drill and I suck like that. I'm little forwarding the incus. This is going up to the mastet cavity. This is the stapes head. So reconstructing the attic and the area with the homograft septal cartilage. Again, I don't harvest any cartilage from anywhere. This is a cartilage bit. I'm keeping it over the stapes head as a type 3 tympanoplasty, and then I will put back the graft. So this is a cartilage that acts as a graft, and I will not make any incision anywhere, totally scarless. This is another case of right-sided timpanoplasty mastectomy. I'm little forwarding the video. So here I am using only one hand to hold the telescope, one hand to drill, and in between I suck, always irrigate very minimal. This is quite a big cavity going up to the masthead tip up to that. This is some cholesteatoma in the facial recess and sinus tympani area, which I am taking it out by reducing the posterior buttress. I am reducing posterior buttress. After removing the disease, it's a highly edited video. I will be reconstructing the attic and the cavity area with the septal cartilage. Always I have a gap between the cartilage and the adductus area for the ventilation from the middle ear to the antrum. This is the second month post-operative. You can see a normal ear canal. Let me play one more video, small video. So big. This is a left-sided cholesteatoma. So far I showed a right-sided. You can see always you have to elevate a very long tympanomeatal flap incision. This is a post-operative. 2 months post-operative, you can see a normal ear canal and normal tympanic membrane. This is reconstructed with the homograft septal cartilage, no scar for the patient. We move on to some revision cases. This is a revision case. I will show quickly. This is a case already operated, left ear. This patient has a very large perforation. You can see a large perforation and a large cavity, but the masthead cavity is not giving any trouble. Only this perforation is giving the discharge. If you are doing microscopically or posteriorly, you have to elevate all this area, which will be very cumbersome thing. But here I just freshen the margins, just elevate this skin alone and cartilage without this freshening the edges of the margin. This is a cavity. You need not do anything. If it is a microscopic method or a post-oral method, you have to elevate all these things and make it a very big surgery. And this patient had a hearing loss also, conductive hearing loss. So I did a cartilage cartilage osteoplasty using the homograft septal cartilage as an inverted umbrella technique. This is a two-stud part of the cartilage, again carved out of the homograft septal cartilage, and I will be keeping it there. And post-operatively, the hearing improved very much. This is an inverted umbrella technique, type 3. Instead of that, you can have a TORP also. Because here the height of the cavity was less, so I was using, mostly I use for a cartilage. Sometimes I use PARP also. I will be showing vasculoplasty also here. PARP at the Teflon also. Over the osculoplasty, I am keeping the septal cartilage as the graft material. So hardly any incision to the patient anywhere, no stitch, and the patient will be going to the work from the second post-operative day onwards. See, the cavity is fine, and this heals nicely, and the hearing improves. So basically, one more video. There's a perforation. There is a granulation in the attic area. All I am clearing it out. And small granulations I am taking raw, irregular bony edges I am curating out. A revision case. And I am keeping a cartilage in the cavity to have a smooth cavity, not to have a post-operative cavity problem. And one more cartilage as a two cartilages as for the tympanoplasty, and put back the flap. So you get a so beautiful result with and you have the homograft cartilage material so abundant, and you can use it. And these patients work very well. and without any scar. So totally scarless surgeries. So retraction, I think I'll be move on to the another thing. Already I have taken already 30 minutes, so I will be moving on. So master drilling. So you can use a drill, or you can use an piezoelectric drills. But I have my own innovations. This is 1 millimeter drill, and this is 2 millimeter drill, which I will be showing. This is my own innovation. Sometimes drills will make a lot of dust flying and everything. If you use a chisel, 1 millimeter, 2 millimeter chisel, it will be very easy. This is a cortical mastectomy. It's a retraction pocket. Drum is intact, and the retraction, and there is an depression in the posterior canal. A little forward, I will just showing the chiseling of this, using the chisel to take out the bone. So chisel is also very much an innovative tool, and I can create a cavity. Again, I reconstruct the cavity with a cartilage after clearing the adductors and everything, and there will be no stitch, no scar. This is a post-operative cavity. No stitch, no scars, totally scarless, and beautiful cavity, but not cavity, beautiful normal ear canal post-operatively. So another one controversy for two hand and single hand during drilling. Sometimes if I require two hands, then what I do, I don't use any endo holders or anything. I just give that telescope to my nurse, like anterior skull-based surgeons holding, giving the scope to their assistant to hold the scope, and they use two hands to do the skull-based surgeries. Like I give it to the nurse and I do it with the two hands. So there is really no need for the endo holders or two hands. Very rarely, whenever you require two hands, you can do this. This my own thing, and I will show one osculoplasty. Again, the incision with my Ahilasamy diathermy knife, elevating the tympanum flap. Drum. Patient had a conductive hearing loss and A-type impedance. So I am using a PARP, over which I will give a cartilage. Again, I will be using a septal cartilage. That's a PARP. I am keeping it over the stapes head. Now after that, I will be keeping again as a septal cartilage, which is a homograft septal cartilage. So harvest cartilage from Conga or tragus anywhere. So I have few more videos of interesting cases, but I will be skipping those things.
Ahilasamy,
yes.
We have a lot of questions. Can we take questions?
Yeah. So I will be finishing in another 5 minutes, and I will take questions, or you want to take it right now?
Yeah, you finish in 5 minutes, then we'll take questions.
Yeah.
Because each one 45 minutes with 15 minutes of questions will have.
Exactly. So far I had done around 35 minutes. So I will be finishing in another 5 minutes. Okay. This is so when you are doing posteriorly, you have a big mastered bandage like this. Previously, I used to take temporalis fascia, then I will have a bandage like this. Now there's small bandage like this. Post-operative day 1, they remove the bandage, and day 2 onward, they go to the job or they go to the office, whatever it may be. My final innovation is my local anesthesia. I do most of the cases under local anesthesia unless it is a child. And my innovation is rupivacaine. Most of you people are using lignocaine for infiltration. I use rupivacaine. It is a wonderful drug. So the pre-medication is previous night I give alprazolam 0.5 mg, pantoprazole, then cetirizine, then on the OT table intravenous fentanyl 100 mics, then followed by dexmedetomidine 1 microgram as per kg body weight as induction dose, followed by 0.3 to 0.0 microgram as maintenance. But this is the game changer. This is the game changer, ropivacaine. I use for infiltration, whether it is any ear surgery or sinus surgery, ropivacaine. The biggest advantage is lignocaine will work for only 2 hours or maximum 2.5 to 3 hours. But ropivacaine works for 6 to 7 hours. It is only anesthetic along with cocaine has a vasoconstrictive properties, so there is really no need to add adrenaline. But for 0.5% ropivacaine in 20 ml, I add 10 drops or 0.5 ml of adrenaline. That means I make it a solution of 1:40,000. Please try this thing. It has the least cardiac and CNS toxicity among all the local anesthetic drugs. This drug was introduced in 1996, and from that onwards it is being used. It has less liposolubility, more protein binding, and delayed onset of action and long duration of action, and it has the least cardiac and CNS toxicity. There is a video on ear infiltration. Let me play during question hours if there is a time. So one thing I want to tell, 3 stages of truth. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted with being self-evident. All my innovations have all passed through all these 3 stages. Please understand. I want to play this video. This is one of Janaki's favorite videos.
Voice is not coming.
One second. Let me try.
No, voice is not coming.
I think voice is not coming.
Yes, voice is not coming.
Okay, there is something with my laptop then. Okay.
But there is some subtitles, no problem.
Okay. Let me finish. No problem. Okay. Anyway, this video is in that video is in internet. Everybody can watch. That's by Stan, who is a producer of these Spider-Man movies. So before I finish, let me say the Bible, the Bhagavad Gita, the Quran of END, Scott Brown 8th edition says, exciting developments in technology and expertise mean that auto-endoscopy is likely to remain a key tool of technique in the otologist armamentarium into the future. The microscope has traditionally been the workhorse of ear surgery, but modern advances in endoscope design and endoscopic surgical techniques have ushered in a new era for the rigid endoscope as the tool in otology. So far in otology, microscope has been placed very well safely like this, but the endoscope has made microscope like this. Okay, Janaki, I will take questions. This is please anybody want to take a screenshot of this thing? You can contact me on this number anytime for your questions, queries. Janaki.
Okay, now you have to stop screen sharing.
Okay. So let me finish and sorry. This is my website. You can log into that. You please. I think if you would have taken a screenshot, then I will move on. And this is my YouTube channel, which has 300 videos. and you can always check it. Thank you for watching. Thank you.
Hello.
I am stop sharing. Sharing. Yes.
Okay, Dr. Ahilasamy, that was a fantastic talk. In fact,
Thank you, Janaki.
I want to congratulate you on this because you see, many people do not have the time or the idea to publish. So I think this is very important. In fact, abroad, even if they sneeze, they publish. Even if they sneeze, they publish. So, but in India, we have, so for example, I'll just tell you, I posted a video on orbital transposition. It's there still in the YouTube, far before it was published. And I just didn't name it as orbital transposition. I didn't publish it. But later it got published from the Varese group. And after, you know, everybody wants to publish. Now, if you take a stitch also, they publish. So there's, I mean, everybody publishes, Bulgarization. Imagine just creating a syneche between the middle turbinate and the septum. And we always call it Bulgarization after Bulgar. So I think there is a lot of scope for Indians. We have a lot of brains, only that we don't publish. And I think if we publish, I think we will go into the, you know, the legacy of ENT. Well done, Dr. Ahila.
Thank you, Janaki. Thank you.
You know, you're coming out with innovations. I think that is the way to go. For the juniors, if you want to make your name, there is no point in just, you know, aping the already published material. So you have to, even a small thing, you just publish it. Whatever journal, just publish it. Even if it can be just, you know, taking the nail out, that small thing can be published. You never know, it can become a super duper hit at some point of time. Only thing is you have to keep talking about it, and that's what Dr. Ahilasamy is doing. Very good. So what I will do is now I'm going to read out some questions. I'll be putting it across to Ahila. There are so many questions for you. Let me choose the questions. Now, Dr. Majumdar has posted a lot of questions to you. I think he's a great teacher from Pondicherry, Jipmar. And he's asking you, Dr. Ahila, would you do extensive mastoid drilling in acquired cholesteatoma cases?
Yes, extensive, and I had showed videos here also going up to tip I had done.
So why are you creating a new attic canal? Another question by him.
New attic canal.
Yes.
No, when we reconstruct, I will keep a cartilage between the mastoid cavity and the middle ear. There will be a gap between the cartilage and the adductus area, that the lateral part, so for the air to communicate between the posterior tympanum, retrotympanum into the antrum.
Okay, now there's a question from Oman by Dr. Jagdish. Do you need to do shaving in endoscopic ear surgery, especially when it is scarless?
That's a very, very important question. Always take out the hair from the ear canal. That is very, 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 very important. That's important than surgery. Either you trim the hair or you put a cream. The best thing is you put Annie French or wheat hair removing cream. They are keratolytic cream. You put a cotton ball into the ear canal so that it doesn't go into the middle ear. Put the cream, wait for 5 minutes, then wipe it like this. People who apply cream on the hand and they wipe it and take it out like that. That is very, very important. That prevents fogging of the endoscope. Otherwise, every time you take the scope in and out, the blood touches from the touching the ear hair will touch to the lens of the endoscope and falls.
Okay, Jagdish also passes a comment from Oman. He says that if the videos had been played full screen, then it would have been better. This is just a suggestion. Okay, Dr. Yogesh from Erode. Sir, any difficult...
Janaki. Yeah. For Jagdish woman, all these videos are in YouTube, my channel. You please go and watch it, all these videos in full screen. So that too, I have here edited videos, unedited videos, same videos, everything is in YouTube. You can please go and watch.
Okay, Dr. Yogesh from Erode is asking you, sir, any difficulty you encountered in adhesive otitis media or tympanosclerosis cases where a lot of adhesions will be there?
I had done few not very big series, few cases of adhesive otitis media. There was a video, but since I skipped, I didn't show it. You can do like a microscopic surgery. Here also you elevate, put cartilage as palisading and put it back. That's all. It's very simple as that.
Dr. Lakshmi Santaram from Bangalore, she's asking you, how did you train yourself in endoscopic ear surgery? What do you advise the young endoscopic ear surgeons?
So it's a very, very nice question, very interesting question. Many people for let me take for endoscopy sinus surgery, people would say that you do 10 cadavers, 5 cadavers, then train on the body, or do lot of diagnostic endoscopy. For microscopy ear surgery, you have to do lot of temple bone dissection. But and nowadays people are advising for endoscopic ear surgery, do lot of sheep head training. You can do training on sheep head, but I didn't have any training. I had a good knowledge of microscopic ear anatomy, and I had a very good hand of endoscopic sinus surgical hand. With that both I had. That's what I told, because after 8 years I was not doing any ear surgery. Suddenly came out, did couple of surgeries with microscope, couldn't do anything good. So with the microscopic knowledge as well as a good endoscopic sinus surgical hand, I did that.
So you advise the juniors to start off doing microscopic ear surgery, then go for endoscopic.
Always microscopic ear.
Go for endoscopic ear surgery.
Always microscopic anatomy, microscopic hand is must, because anytime if you have a difficulty bleeding or anything, if you want to switch on, you should know the thing. And drilling the bone on the temple bone dissection, that all comes with temple bone dissection. And if you want to have a endoscopic hand alone, you should have a good endoscopic sinus surgical hand. Along with, if you want, you can train with sheep head. Sheep head you can train.
Okay, Dr. Brijesh Kumar from Jaunpur. Sir, chance of recurrence for this limited mastectomy is there?
It is not limited mastectomy. It is limited mastectomy, yes, of course, but it is complete disease clearance. If you leave the disease begin, whether it is an limited surgery or a very, very extensive microscopy surgery, if you leave the disease begin, you will get recurrence. If you clear the disease, that's the answer.
Okay, Dr. Ajmal from Rawalpindi, he's asking you, why not you use homologous septal cartilage? I have used it with good results.
Yes, you can use it. You can, but the results are same. This is one more surgery. You have to convince the patient. Okay, if the patient asks, I don't want an homographed septal cartilage, well, you can go again. This is easy way. You have already a cartilage bank with you, and you save a lot of time of harvesting the graft, everything. But very well, you can very well have a septal cartilage. Yes.
Now, another question by Priya Kanagamuttu, Chennai. While drilling, if we use endoscope, will bone dust hide the view or any damage to the endoscope in your experience?
Bone dust, if it flies, it always occludes the vision. So you have to irrigate drop by drop. If you flush too much also, then you can't see. So you have to irrigate drop by drop. The best tool is piezoelectric, but it is very costly. It costs around 20 lakhs or so. Janaki knows the exact price. And so that I have innovated the new chisel, 1 millimeter, 2 millimeter chisel, in which you can you have a steady hand, then you can take bits and bits of bones, then you can finally, small areas you can drill it out.
So Sandeep from Jammu. So you're having viewers from all over the world, my dear friend. Oman.
Thank you, Janaki. Thank you, Janaki.
So from Jammu, Sandeep asks, sir, how do you reconstruct if middle mucosa is edematous or polypoidal?
How do you?
Reconstruct if middle mucosa is edematous or polypoidal.
Okay, fine. Always, all these patients, I treat the patients pre-operatively with some steroids and antibiotics for 5 days or 1 week, so that the medullary infection comes down. One thing, the chance of post-operative infection is less, and during surgery, when it is edematous mucosa or more infection is there, the chance of bleeding is more. So always I treat the patient and take. Okay, if at the time of surgery still there is a lot of edema and edematous mucosa, then again I go ahead and do the same thing, same technique.
Okay, so one more question from, so you're getting so many questions are pouring in, but we don't have much time. I'm going to take the last two questions. Dr. Rajalakshmi from Bhubaneswar is asking you, how far can we use chisel without complications?
Okay, you should have a steady hand, whether it is chisel or whether it is drill, you should have a steady hand. Even with the drill also, if you don't have a steady hand, you will go in and poke the vital structures.
Yeah, I think the fool behind a tool is always a fool. So,
yeah, very well told, Dani. Very well told.
So I think the last question, I'll take it on a lighter note. Dr. Ashim Kumar Banerjee from Kolkata is asking you, where are you sitting? Are you sitting in a beach resort? And where are you sitting?
secret location.
Okay, right. So he's from a secret location, maybe gone for a vacation during the COVID times because of lockdown. Okay, so Ahila, you had a fantastic response. 3 cheers to you. Wonderful talk, and more importantly, we are proud to say that you are from India and published a lot of innovations. Thumbs up. Okay.
Thank you, Janaki. Thank you, Andrew and Vetrivel, and all the viewers. And if further still any questions at the end also.
Wait, we'll take questions for you at the end. Dr. Majumdar sir has asked so many questions. I will ask all the questions after.
Janaki, at least ask. Oh yeah, already you asked one question. Okay, fine.
Yeah, so many are there. So many, more than 75 questions have come already. Prakash Munka sir, Ahila, you prefer curettage more than drilling? Our Prakash Munka sir is there. Good evening.
Yeah. I will answer that question. Initial steps, I curate. Always curate is better because the bone doesn't fly. You can do it with one hand holding the scope and one hand usually curate. But after a limit, the bone will be very hard. You have to either chisel or you have to use the drill.
Okay, very nicely answered. Thank you, Dr. Ahila.
Thank you.
Right for India. And now we go on to the second speaker. That is Professor Anthony. He is he's a professor in Madras Medical College. My classmate, Encyclopedia of ENT, you will see that. And of course, a brilliant surgeon. In fact, I like his head and neck surgery more than anything. But I think to the best of my knowledge, he does endoscopic stapes surgery with a class apart. You just have to see his videos and you will know what he is. For the speakers, just want to tell you that we'll have the lecture for 40 minutes and then we'll have 20 minutes of questions. If you go for 1 hour, then we'll have less questions. So question answer gives you more interaction. So here we are with Professor Anthony. Over to you, Professor Anthony. Can you unmute yourself? Unmute yourself, please. Yes.
Am I audible?
Yes, are you audible, please?
Good evening, Janagram, Vetri, Agils, and the team of club. First of all, I want to remind all of you that I am webinars. So if I am not very comfortable in handling these gadgets, kindly bear with me, right? How do I go about it?
Now, Harsha, take over, please. Harsha, are you there? So you have to screen share.
Yeah, fine. Right. Click the first screen share. What's happening?
Harsha, can you help him?
Yes, sir.
Asha?
Yes, sir. Let me know, sir.
Sorry?
Let me know, sir. Any issues?
Yeah, I don't get the videos. I mean, I don't get the screen.
Your screen is visible, sir, for us.
Yeah, your screen is visible, Anto. Just make it the presentation mode, and then start.
I don't know how to make it presentation mode. That's right.
Press F5, sir. F5.
M5. F5 or M5?
F5. The upper row keys. Yeah.
Yes, right.
Yeah, your screen is seen. You can carry on, Dr. Anthony. We
One
can't
minute.
hear you.
No, 1 minute. My screen has become very small now. Okay. So, good evening, everyone. I am going to talk about endoscopic stapes bypass surgery. Everybody is everybody is much worried about doing surgery with an endoscope because of the fear of one hand held up and um, one hand held up and it's very difficult to, they feel it is very difficult to get trained with an endoscopic surgery. When you do an endoscopic ear surgery, the pinnacle of otology is stapes surgery, right? So you can do a lot of things. You can do an extensive surgeries, like you can do a lateral skull-based surgeries with a microscope in the ear. You can do a transcochlear approach and things like that. But the finish, or what I call the queen of ear surgery, is stapectomy. So doing a stapectomy with an endoscope gives you an ultimate authority in doing endoscopic ear surgery. You could have seen, I am Dr. Anthony. I am a professor in Madras Medical College in RGC at Chennai. As Janagram has said, we were all studying it from the period of 94 to 97, 98. And we had a fantastic time together. And this is my alma mater. This is a place, I would say, rather the birth of Indian endoscopic ear surgery has started. Rather, unfortunately, because of lack of so many things, we started doing with an endoscope. But we have done our first endoscopic ear surgery workshop. We have started doing this in 1997, 98. And we did our first live surgical workshop in 2002 or 2003. So this is a place where the doyens of endoscopic ear surgeries are started. But the problem with that is that, as Janagram said, they are not published. It's not known to the world. When people who started doing these things after a long time or projecting themselves, it was very, the name of Madras Medical College in the endoscopic ear surgery has slowly come to the backstage. And to an extent that even to the Chennai, they call people from outside. But the truth is that in Madras Medical College, we train about 30 postgraduate students per year. I am coming again, 30 postgraduate students per year. That means we are having about 90 students. And all these 90 students do the most of their year work with an endoscope for the past 10 years from the Madras Medical College. This is how, when Vetri or Ahilasamy are doing an endoscopic ear surgery, it's we have been doing like this from 20 years, right? So from 1984, this fellow is my friend, and there were times when we were friends, and then we were friends, and slowly he has got elevated. I mean, I was doing my post graduation first, and he was following me, and I used to call him my younger colleague. And in status, slowly he has become a nationally known, and now he's internationally known. And he said, when he had a doubt, he used to just call me. But for everything, I used to just call him because he's my role model. And I know it is how difficult to see him at this standard today or this stature today what sacrifice he has done is very difficult for others to see. And he is a workaholic, and he likes operating. Believe me, he likes operating. He likes operating for 2-3 days continuously without a sleep also he'll operate. Only thing is, he likes doing very, very challenging cases. And then from there, I am going to my presentation with a little scare because I want to have my videos right. Do I get my videos?
Yes,
Yes,
sir.
yes,
Yes.
clearly seen. Only thing is try to make it bigger. Many audience want it a little bigger. Make it bigger. Ah, yeah.
That's
Okay.
fine.
Good,
Yeah.
good.
This
Yeah.
is the edited video of endoscopic ear surgery. I mean endoscopic staphylectomy done recently, uh, about 2 years back. Right? You elevate a tympanometer flap. The advantage of staphylectomy with an endoscope is that we can see all the structures focused at the same time together. You can see an axillary canal, you can see a promontory, you can see a stapes, and you can see the incus, and you can see a stapedial tendon all at the same time, right? So once you elevate a tympanometer flap, it's always when the patient has got a both sides equal hearing loss, you are given a preference. We like to do it on the left side because removing the bony overhang is easier. And then how much you remove the bony overhang? It's another question. See, this video is only to show you how to do a staphylectomy endoscopically. It's a well edited video. You can see the fenestra. You suck the fluid. You can see a small fenestra. You take the piston, insert inside first, and then put it over the. Most of the time you can do it first shot without much of a difference. Crimp it adequately. If you like crimping, you can crimp it or you can leave it alone. Then you cut. I always do a reverse staphylectomy, except in very few situations. Right? So remove the suprastructure. Take it out. I always keep a small amount of earlobe fat or soft tissue in the around the piston. Small amount. Replace it. Okay, right. So this is another video which is done in government general hospital. I was watching Ahilasamy. I was really impressed with this knife. It's very nice. So seeing this bloody things, but when the patient has got a bleeding, you need not worry. All you got to do is it's a 1 or 2 drops of blood which can be sucked up with a cotton ball. You keep a cotton ball, and then the blood will get sucked. You keep the cotton ball on the dependent area, and you can elevate the flap easily. You can see how you can elevate this patient was bleeding. In spite of that, we can elevate the tympanometer flap. Go on inside the middle ear. I elevate up to the level, I see a malleus, annulus the malleus. But I'll tell you, I do statis regularly. I was a professor in HOD in Salem, where I learned to do I used to get a lot of revision staphylectomy. So all my revision cases, everything I learned only in the Salem. But what I want to tell you is that even though I was very happy doing staphylectomy anywhere, even in the live surgery workshop, stapes is the boss. It can give you trouble at any time. Okay. This is the government hospital where we thought not see, this is the vision of a posterior crura, and you can see a small adduction. That is the vision of the foot plate. You can even see the this is the skeeter drill. You can go to the posterior part of the foot plate and use the skeeter to make a hole. Okay, that's a fenestra. You can use a small section. Don't use it over the fenestra. Use it around the fenestra so that it will, this is the hole what you get. This vision is very difficult to get with the endoscope. I mean with the microscope, where you will not see the posterior canal and fenestra in the same view. So you keep it on the hole and then push it over. You strip it. The difference between the surgery outside and in the okay, you can cut the stapes. I mean, you can cut the stapedial tendon. Use the either to thin the posterior crura. Then you dislocate the interosseous joint. Then you can remove the stapes, superstructure. And then put it up. Right? So, stapes surgery from the time of the stepidotomy or posterior small fenestra stapedectomy, it has evolved a long way in the sense that we started using laser, we started using heaters, and we started using other things. Then where is the question comes, why endoscopy in a stapes surgery? The endoscopic stapes surgery is for the young otologist. It's not for the surgeon who does the stapes fantastically with the microscope. If you are a surgeon, you are very confident of doing your surgery with the microscope and you have no issues at all, please continue doing it. Because when you are becoming an ENT surgeon, you got to learn so many skills. Like you got to learn a mucosal surgery, like you got to do a septoplasty, SMR, and then tonsillectomies. And then you got to learn a microscopic surgery. And then you got to learn endoscopy also. On top of that, some people learn so many other things. So when you learn something lesser, like when you can manage nodes with an endoscope and the most of the year with an endoscope, it's easier. So young otologists, it's always easier for them to get trained in the ER. And this is the today's training program, as Ahilasamy said, or Janakiram said in some of the my lectures before, that when you go to an American academy, most of these lectures or most wanted lectures are all about the endoscopic stapes surgery. And it's a today's training program. And we propagate what we do. Okay, so advantage of endoscopic stapedectomy is that it's a better total vision, panoramic vision. You see all the structures from the temporometal flap to the stapes foot plate at the same view. If you want a bigger view, nowadays you have a very good camera. All these cameras come with the zoom. You can zoom it, or you can go near, and it's a wide angle. Very easy adjustability. For example, you need not increase the zoom in the sense that you need not increase from into 10 or into 4 or into 6, things like that. You go near, just to take it inside, it will become nearer. To take it outside, it will become wider view, and that the zoom facility is there. And everybody get trained in the chest surgery, so making it very easy to do an endoscopic ear surgery. The problem with an endoscopic stapes is that it's a single-handed. There is a problem with the vision, particularly when there is a narrow canal, the flap elevation, removing the bony overhang, pistol insertion and making fenestra, and latest gadgets and difficult situations. These are all the headings under which we are going to see the stapes surgery. Before that, I want to show you how they do a classical microscopic surgery. So this is how they make an incision. This is one of the very good microscopic surgeries. You can see the two hands here, right? They are elevating, and there was a suction. After that, everything is done with only one hand. See, this is the dislocation. Okay, and then there is a fenestra. See how many hands are used? Only one hand, right? So they are removing the superstructure. They make a skeeter hole, and they make a fenestra. And stapes foot plate is surgery. How many hands they have used? How many hands? One hand. But we make so much fuss when you are doing a stapes with the single hand. So single hand is not a problem. Only thing is your mindset is the problem, not the single hand. And then when you are talking about training, if you are a junior most person in the training schedule and you are a senior resident or you are a junior resident, you get the worst microscope, worst endoscope, poor visibility like this. So this gives you a bad taste of doing a stapes surgery with a endoscope. But once you have become a bigger surgeon, nowadays you get a fantastic endoscope, fantastic cameras. You get this side you get Olympus 4K, that side you get a Stars 4K or a Stars image. So all these things give you a fantastic vision. So that's not an issue. When you are talking about stapes, why are we afraid? We want to put a piston like this. First shot. Yes. So we are worried when you do it with only one hand with an endoscope, can we do like this or not? But it's not very difficult to do like this. We'll see how are you going to do about it. Fine. So what are the prerequisites for a good stapes surgery? It's an uncomplicated surgery. Your mindset should be clear. So elevated temporometal flap, it should be clear and should give you a good exposure. So when you take an endoscope closer to the foot plate, you get the very good vision. If you are away from the foot plate, very close to the external aortic canal, you get the smaller vision. But you are going to put when you are going to go near the posterior canal wall's end, annulus, you see everything. But that's not the way you are not going to put your piston, because piston can't bend. So you got to remove the curating. In spite of getting a good vision, it's always safer to remove the curating, particularly when you are a small surgeon. The tip of the forceps and the piston and the foot plate all should be in a straight alignment so that you can put straight inside. A proper technique, more so it is supervised training. In myself, Ahilasamy, Vetrivel were bragging that we never had training, we do this, we do that, but that's not the way to do it. To do it, you should have a proper training. To have a proper training, it should be a supervised training. So, flap elevation. Is my video is seen?
Yes, sir. Yeah, you can go ahead, sir.
Yeah, fine. So, see, you make an incision. Don't go very close to the annulus because when you remove a bony overhang, you need little bit of space. So this is how I remove the blood. You keep a adrenal soaked cotton ball, suck the blood. You keep sucking the blood. Once the cotton ball get colored, then you can remove the cotton ball and get another cotton ball. Till then you can use the same cotton ball. So that's the annulus. When you go near the annulus, just go for a dip and elevate the annulus. So if you tear a flap, thing will happen, you can always adjust the flap or put a small soft tissue on top of that, or even you can put a graft. But the thing is, you will get moved out and all other steps will become bad. This is like when you are writing your exam, write the first question, answer beautifully. When you are satisfied, all your answers will keep coming regularly. Okay, so then second thing is a product. Use a cauda probe and pull the cauda away. So nowadays we don't remove the cauda. We can still remove a little bit of bony overhang and do it. But removing cauda is, there will be an addition between the cauda and the incus. You got to remove that, and then you can see there is a small bone which prevents the cauda going away. So you remove that bone with a curette. So once you remove the bone, otherwise I call it as a decompression of cauda, like a facial nerve decompression. Then you pull it on the opposite side. So even after removing the bony overhang, you remove the bone which holds the cauda, which will give you the better vision. Then removing of bony overhang. This is another thing which everybody is worried when you are doing a stapes surgery. See, this is the area which the notch. From the notch, you can easily remove the bony overhang. When you are doing on the opposite side, which is little difficult, but this side it is much easier because you have a nice place to hang it on. So you give a hang there, and from there keep removing the bony overhang. I used to do my facial nerve decompression most of the time with a good curette. What you see is the facial nerve here. Okay. So how much bony overhang you will remove? You can, it's not, you can see up to the base of the pyramid. Why? Because it's not that area of interest is the fenestra. The area of interest is the head of the piston. So the head of the piston should go inside. To take the piston inside, you should have a bigger area. See, like this. The head, this head, when you take inside, should not hitch upon this area. If it hitches, your alignment will change. So this whole head should go inside this area comfortably. If it's not going, you can still adjust and put it inside. But for a learner, you want to do it perfectly, you want to do it without any problem, this is how you should do it. Then you make a fenestra. So making a fenestra, see, this is a white opalescent type 2 footplate, right? I used to make it with a perforator. The white opalescent footplate with the perforator, you should know that you make the perforation with the feel, not with the vision. So once you make a small hole like this, you can see a very minute amount of perilymph coming out. So that's the hole, right? You use a right size handbag. So this is the perfect piston. I mean perfect fenestra. And we usually avoid um, sucking the fenestra straight. Most of the time we keep the suction on the footplate away from the fenestra. Okay, so you say nowadays we don't use this, we use lasers, we use heaters and things like that. We can still use heater on the endoscopic stability. See, I am very happy about inserting the piston usually with the first shot. So we can keep seeing this, right? See, it's another fenestra on the opposite side. That was on the right side, this was on the left side. You can see the hole. Fantastic, nice punch out. See the fenestra, see the piston. Beautiful. So fenestra is not a problem. You can easily do a fenestra very well with the endoscope, right? Then piston. How do we insert the piston? You can see the fenestra, right? Perfect fenestra on the posterior part of the footplate. Take it there inside and hang it. Okay, you can check it out. Fenestra is there inside the footplate. If you want, you can do a hanging test and the bending test. Then do a reverse physiectomy and this take out the footplate. I mean, take out the suprastructure. Sorry. Then I told you always keep back, because when you are doing stapes surgery, it's not always you get the perfectly aided sometimes the hole will be bigger, sometimes it will be smaller. Then always keeping a seal is ideal. There was a time we used to take a vein graft to keep a seal, but nowadays we don't bother about that. Those days we used to take the vein and put that intimal side inside. All these things are all proven that not required nowadays. Okay. So narrow canal. How do you do? How narrow the canal you can do, right? So this is a patient who had an injury in the temporomandibular joint and the joint dislocated backwards. You can see how narrow this canal is. How do you do? Go near that narrow area. The narrow area occurs on the bony canal, right? Go near that narrow area. Once you have gone near that narrow area, then it's not a problem. So this is a patient who underwent stapedectomy some 15 years back, and now he had a bad hearing on the opposite ear as well. So this stapedectomy was done. This was done at a lot of difficulties because not because happened like this. This fellow is known to me because I have done a staphylectomy 15 years back on the opposite ear, and this patient desaturated once he given the pre-med. Then we have intubated the patient, did the staph surgery. So it was under enormous tension of desaturating and an emergency intubation and still doing a staph surgery on a patient's canal. You can see the fracture and moved anterior canal walls, but the status is on the posterior part of the canal, and even the anterior canal wall can be seen if you are going near to the narrow area. Okay. So narrow canal is not a contraindication to do a endoscopic staphylectomy. There are a lot of things which comes in the book which can be done. It can be presented and which is proven for some time only will come in the book. So whatever things we see in the book is true. At the same time, when you have practically when you do these things, you can always know that. You can do, for example, when they think when you do an endoscopic cholestoma surgery, we don't operate if it is lateral to the lateral semicircular canal, but we can operate even to the level of a tip, provided if you know the technique how to do it. So this patient, this is a staph piston insertion. But the only drawback on this patient was we couldn't check the hearing because he was under general anesthesia. We have crimped it nicely. And the cauda was by itself has gone to its position just lateral to the head of the staph. We removed the superstructure. And then we kept the fat. So the other one, narrow canal is not a contraindication to do an endoscopic staph. In fact, endoscopic staph is the ideal thing to do when your patient's canal is very narrow. Because this patient, I don't think with the microscope good surgery to have been done, but still, as I told you, when I can do it with an endoscope, there are people who can do it with the microscope also. So then we go into how to insert piston. So this is my movie. Can anybody tell me whether that sound is coming with the video?
Yeah, sound was coming actually, but now we have stopped the sound, I think.
Now is it coming?
Yeah, it's coming.
Yeah.
You want the sound or you don't want the sound?
You don't want the sound.
No, I'm asking you, you want to have the sound along or?
I think if I reduce the sound, that can you hear me?
Yeah, I can hear you.
Yeah, then it's fine. So these are all the points we have already told you. See, the most important thing about piston insertion is its alignment. How do you check the alignment? You got to touch the foot plate with your finest suction straight without that touching on this area. Till then, you got to remove the bony overhang. This is not sufficient, but when you can touch the posterior part of foot plate with a suction tip, without any hindrance, then we can put the fenestra. And the second important thing is, you want to take the fenestra, hold it like this, not like in such a way that your hand, this is the way I hold it. The hand the instrument, the foot plate, the stem of a piston got to be in the straight line. All these things are in the straight line. You can directly put it over the fenestra and put it inside straight first shot. See, this is another case on the other side. Take it. And then any number of piston insertions. I have close to 60 piston insertions like this, all of a shot. Whether it's bleeding or not bleeding doesn't matter. You just keep it there and just adjust it. That's all. See this side, another one. Put it inside the hole, hang it over. As simple as that. See, the thing is, take it, keep that in a straight line. So this you already checked up with your endoscope, with your suction tip going inside and touching you, so you are sure. So take it out, go there, put it inside. These are all my previous cases where you can see that camera is not very good. You do the single chip camera, do the striker 1088 camera, and even till now we have an image one. Still, all these cases we can easily put a first shot piston only if you follow the thing. See, this patient has got a narrow niche and a decent facial nerve. See, that's also is not a contraindication to do. You can, if you don't have that fenestra area, then you can remove it. So this is the another case which I'll show you of perilimb fistula, perilimb gusher. So everything you can manage. Insertion of the piston is easier. So how do you manage perilimb gusher? Okay, when you say when you have a gusher, how can you put a fenestra? 1 minute, I will go back. Let's check out what is this. See, this is the hole. You can see 3 instruments here. This is a endoscope is there. I am inserting the piston, and then there is a suction inside. It's a massive gusher. You just leave it for a minute, see how it's coming out. Still, how I manage is you keep a gel foam here around the whole window area, keep a suction on top of that, and hold the suction with the posterior canal wall with the endoscope, press it up so that it stays there. Once you have done that, Johnny Graham?
Yeah, I'm there.
You want me to, if the time is there, or?
No, if you have somehow you can, maybe we can take a lot of questions. A lot of questions are coming. I think you've shown a lot of Steppies cases.
No, this is a, okay, fine. That's what I also thought. So advances in the Steppies surgery, this is the one slide I want to show you. This we have seen. So heater can be used comfortably. It's a deep niched foot plate. You can see the fenestra beautifully. This heater makes one of the good or better fenestras compared with that of the um, our our handbars. See, beautiful, nice punched out fenestras. No, why I am showing so many fenestras are because you don't think that it happens once in a while. No, we do it regularly. So thank you very much. This is my team. We have had a hello.
Yeah. You have to stop share.
Stop sharing. How to stop share?
Okay. That was a brilliant presentation, Dr. Anthony. It looked like a piece of cake, like a laddu. It was. You are just showing single shot pistons. You're making stapes look so simple, but to tell you honestly, for the sake of juniors, it needs a lot of practice. And one thing is the advantage of Professor Anthony is that he's working in the Apex Institute of the state, where you will have oceans of cases. You would have done
All gadgets. The government has arranged us having all gadgets. You have an high-end endoscopes, high-end cameras. Our institute is very close to that of Royal Pal. All the big instruments come to Royal Pal first, and we copy that.
Okay, let us now take some questions, Dr. Anthony.
Yes.
Ramaniraj sir is there. He's been seeing you. Wow.
I want to tell you this. I want to tell you this. Sorry. I used to do a statics with a microscope. My cousin brother had a photo. I was able to operate. Sir was my senior colleague, my friend, philosopher, guide, and my Guruji. So I was just telling him I want to do a statics. He told me, use your brother. Why you want to operate? I asked him, whom should I ask, sir? Then he said, yeah, I'll come and operate. He came, he did the first endoscopic staphylectomy, which I assisted. I was his, both of us were assistant professors in the Madras Medical College, and he was my teacher and my senior colleague. So that is the time I shifted from microscope to endoscope. Yes, sir. What's the question?
No, he's actually commented, very nice presentation, wonderful surgical demonstration, Anthony.
Sir, if you would have presented along with this, my presentation would have become nothing, sir. I know how wonderful hands you have.
He's Mr. Perfect. We call him Mr. Perfect, Dr. Ramaniraj sir.
Yes.
Lovely surgeon. I learned a lot from you, Ramaniraj sir. All of us learned a lot from you.
And another interesting thing is that I taught his son staphylectomy. I tutored. He's my assistant professor, youngest fellow. He just and I should tell him probably his father would have done his first stapes surgery around 35 years, but he did it around 24 to 25. Like your son and you, that fellow did his stapes surgery, and I used to see him. He got a wonderful hand, and I was supervising him doing the stapes surgery.
So the father taught a student, and the student teaches son. So this goes on. See, the legacy continues, and then his son will teach your daughter, and it will go on like that. Yeah. So that's beautiful. Actually, we'll have some questions. We have one from Oman. What is your experience in obliterative focus and endoscopic approach? Because you need to drill a lot.
You have a heater, drill it up. That's all. Or you use a handbar. For an all you need is you got to be patient. Don't try to plunge it inside. Keep on drilling. Then you see that blue line. It is like a simple step. And the advantage is you should go for a right angle. If that angle is perfect, then insertion is nothing. You go inside the mount, push it inside, you go. If your angle is not straight to that of incus, then it's very difficult. You got to make it wide and need to burr a lot of area.
Yeah, so that's a very good answer. Again, our Professor Prakash Munkaji from Bokaro. So our brother, friend, philosopher, guide says, Dr. Anthony very well demonstrated step by step how step-piece is done. Did you encounter gushers? If so, how do you manage? Do you have to convert to microscopic or from a local to GA? What is your method?
The only video I skipped is the complete video of the prelim lecture. It's a little big video about 5 minutes. That's the first time I'm seeing a gusher with an endoscope when I was doing in my center.
Your voice is breaking.
Sorry?
Your voice.
And your voice is breaking. Ask your family members to switch off the internet themselves. They are using. Only you use the internet.
Yeah, I think that's what is happening here. Hello?
Yeah, now it's better.
Yeah. So I called him. He was in the traffic, so he didn't pick up the phone. So I told you how I do it. I just put the suction on top of that, and then held the suction with the posterior canal wall with an endoscope, and then with another hand I just inserted the piston. It looks very odd, but I used to give stapes for all my postgraduates. So one postgraduate, now she is in Salem. When she did her first case, she had a gusher. I was gloved and standing next to her. I asked her whether can I come and do it. She said no, and she did it. So gusher is not a problem with an endoscope.
That's why all the postgraduates are actually behind you. Actually, he is one of the most favorite professors. Everybody wants to get into his unit. People are mad after Anthony. I know that. Now, another question from Dr. Prakash Munkaji. He's asking accuracy of hearing test done clinically after putting piston.
I don't check the hearing. Only I whisper. That will be, and usually the airborne gap kosher will be close to 10 decibels of hearing loss.
Now, Dr. Majumdar is our professor from Pondicherry. He is watching you very keenly. He says, very, very good measured dissection. You should be the next director and professor. Of course, he's asking a question. Chorda should be placed superior to the piston. What's your comment?
Chorda placed superior to the piston is fine. Nowadays, I just let the chorda go over and keep it back, which I am just preserving it to present it as a small access static surgery. So that is the case. I keep the chorda and then put the piston. Otherwise, when you put the piston and keep the chorda, it acts as a barrier so that it will not split downwards. Particularly if you induce the lenticular process of the.
So, Dr. Narendra Kumar from Chennai is asking you, dear professor, what was your most difficult situation in stapes surgery? How did you handle it?
Who's that?
Dr. Narendra Kumar.
Narendra Kumar, yes. Fine. Most difficult was my first gusher. And then I told you, when I was in Salem, I used to do stapedectomy in half an hour to 45 minutes time. One day I was operating outside in Salem to one of my friends. When I went there and opened my instrument box, there was a Mollifrons retractor. I was laughing for a stapes surgery. Then I started doing it. I injured this one, tympanic membrane. When I removed I was up. I incus, and it was bleeding. So it took almost 2 hours, 2.5 hours for me to complete that surgery. Then
your voice is breaking, Anto. You have to ask everybody to switch off the internet. Your voice is breaking a little.
Is it okay now?
Yeah, better.
Yeah. So sometimes stapes decides how long it takes, how much ever you are. Sometimes you land up in problem. That was my most difficult time.
Okay, Dr. Mamta from Jaipur is asking you, sir, do you have any chance of having a floating foot plate? And if so, how did you manage it?
Floating plate I never had because we always do a reverse stapedectomy. So in reverse stapedectomy, the chance of floating foot plate is not there. If there is a floating foot plate on any situation, like you do a microscopic or endoscopic, very irrespective of that, if you are doing remove the suprastructure and then you try to make a fenestra, if you are not here, there will be a floating foot plate. There is a lot of on the promontory, try to insert an instrument and take it out. If it's a submerged foot plate, floating foot plate, ideal thing is leave it off like that. Put a graft on top of that, or put some cotton on, put some fat on top of that. Give it rain out. After some time, it will reach it. You can always open it up and do a stapedectomy. If it's a submerged foot plate, then it is difficult.
Okay, we have a question. So Ganpa from Trunaveli says, wonderful master class going on. So where do you get your piston for?
Vetrivel. And he knows where we get the piston from. We used to buy it in front of Madras Medical College, which is about 50. You just tell me, I'll tell you. You get a good, decent piston, which is from Vetrivel, which doesn't cost you much.
Okay, Professor Majumdar is asking you, what is the average length of the piston you generally used?
4.5.
4.5.
Yes, usually 4.5 or 4.5.
Okay, there are people from Iraq, so many countries watching you, boss. You're a famous guy. Hussein from Iraq is asking you, did you face a case of persistent stapedial artery? Okay. So Minis Juvikar, wow, the one of the best otologists in the country is asking, just telling good lecture. So what would you do in a revision case, revision stapedectomy?
Same thing. You got to decide. You got to be mentally prepared to do whatever you want to do.
You take a scan or something like that before cone beam CT. What is your protocol for a revision case? Or for normal stapes, do you take a CT scan of every
normal
case?
cases, I don't take CT scan. If the patient has got a mixed hearing loss, then I take a and you open up the case. One case I saw, whole thing was complete scar. There was old foot plate, stapes, and foot plate. Your piston, everything was complete active scar, ready scar. I just closed it up and then I have come out. But most of the time there will be a little bit of fenestra will be there, and there will be a slipping of a piston. You take it up, refashion it, and you can always do it. That somebody else has done the case.
So we have a question from Dhaka, Bangladesh. DGM Akaid Zaman is asking you, you always prefer microdrill than skeeter? Which do you prefer?
Skeeter.
You prefer the skeeter to the microdrill?
Yes.
Okay. So Dr. Minesh Juvikar is asking you, how many times have you shifted to a microscope from an endoscope during stapes surgery?
Microscope to endoscope during stapes.
No, the other way. Endoscope to a microscope.
That's what. From a microscope to endoscope, I have shifted when some of my colleagues were doing that. I just want to do it. From the endoscope to the microscope, 0 time.
0. My God, fantastic, fantastic. So you are a true endoscopic stapes surgeon. There is no doubt about it. Okay, Dr. Raghu Kumaran is asking you from Namakkal. what about using fat around the piston? Do you advocate that?
Most of the cases I keep.
Where do you harvest that from?
Stab on the lobe, ear lobe.
Earlobe.
Posterior,
Okay, right.
posterior wall.
So I think we had a wonderful session, Dr. Anthony, Professor Anthony. Really enjoyed it thoroughly, and you made stapes look like a piece of cake. That's it. So I mean, I'm thoroughly impressed. Thank you very much. Maybe if I have a stapes problem, I'll come to you to get operated.
Janaki,
Yeah.
Janagiram, I was
Somebody was actually wanting to ask you a question.
Ahilasamy.
Ahila, yeah.
Janaki, one word to wind up. It was this lecture by Andrew was an encyclopedia on endoscopic stapedectomy.
Absolutely, absolutely. Fully agree with you.
Janagiram, I was volunteered to talk about the endoscopic cholestoma surgery. You are the one who insisted me to do the stapes. So thank you very much. எல்லா புகழும் ஜானகிராமனுக்கே.
இல்ல எல்லா புகழும் இறைவனுக்கே. And I've seen you doing stapes. That's why I wanted to show the audience how you can make it so simple without any problem. I've seen you doing it, and you are an absolute delight to watch when you do endoscopic stapes surgery. Thank you, Dr. Anthony. But stay back for Vetrivel's lecture, and then we'll have a good gala time after the lecture. We'll have some questions also. So thank you again, and we will go on to the next lecture of the day by Dr. Vetrivel. And Vetrivel is a very peculiar character. You know why he's peculiar? Because you should have, I'm telling you, I've seen him right from the beginning, from his career. When he dives very hard. That is, he goes right into the depth of everything, and you know, he sleeps with the temporal bone. I've seen him all around the pillow. He'll have temporal bones, and keeps dissecting. I'm telling you, I've made him, you know, demonstrate in our workshop as well, and he's demonstrated in several workshops. He is a delight to watch when he does temporal bone dissection, and I think he's going to talk today on both. So we saw a completely new topic, innovations, and second was endoscopic stapes surgery, and now we're going to see something like a hybrid surgery between the endoscope and the microscope. Let's see what Dr. Vetrivel has to say. Over to you, Dr. Vetrivel. Are you sitting in some other galaxy and talking, or where are you from?
No, the same place.
Okay, over to you. Thank you.
Okay, thank you. Good evening, dear friends. I hope I am audible.
Yeah, very well.
First of all, let me thank my dear friend, Dr. Janaki Ram, for giving me this excellent opportunity to share my ideas in front of a great forum. Right? He is my well-wisher, and without him, today I am not here. Okay, in my life, from the beginning, he has helped me in so many ways, which I will never forget. And I have got the privilege of telling me, my close friend, because nobody will have the experience when you are sick, your friend carrying you to the hospital in an ambulance 3 to 4 hours from your place to another place, shifting you, giving the atmosphere more than a surgeon, a caretaker as a friend. Thank you, my dear friend. And there are no ways to thank you. I also thank my friend, Dr. Ahilasamy, who is my trigger. Okay, he is my trigger factor. I was not active for around about 15 years after my ENT career. He was the trigger factor in my life who triggered me to reach to certain height in a very short span. His lecture was excellent, and we appreciate his innovations in endoscopic ear surgery. My dear friend, Encyclopedia of ENT, Dr. Anthony, you are always a very glad, cheerful, humble, helping person, and you are in great heights. We pray you achieve more and more heights in your life. Basically, I am a microscopic surgeon. I started my career like that, and then I traveled towards the endoscope. And then initially we have the plenty of collection with microscope, and then we gathered a wonderful collection of endoscopic ear surgeries. My videos are available in the YouTube site South Zone ENT 12002. South Zone ENT 12002. So all my single-handed endoscopic ear surgeries are available at that site. My temporal bone dissections are available in the YouTube. Before an surgeon, endoscopic surgeon, ventures into an endoscopic field, it is essential to do a microscopic dissection and to do a few microscopic ear surgeries. Why is this? Because one day you will definitely come to a complication. You have to face a complication just like a general surgeon doing laparotomy. So never say I'll be only an endoscopic ear surgeon. You should be basically a microscopic ear surgeon, and then you push on to the endoscopic ear surgery. Before going into endoscopic ear surgery, you have the practice of doing your outpatient department with endoscope. You have to screen all the patient with endoscope. You have to have the feel of the endoscope before going in for an endoscopic ear surgery. So I have got plenty of DVDs which are published in various conferences, and they are available in my YouTube site, South Zone ENT 12002. And I have edited a book for postgraduates, that is ENT exam point of view, authored by my Professor Gananathan and Karunakaran. And I have released a book for PG entrance examination. Now I am going to talk. I operate with microscope, I operate with endoscope, and today I am going to talk the MIAS, what is MACE or microscopic and endoscopic assisted ear surgery, where you can start with an endoscope, finish with the microscope. You can start with the microscope, finish with the endoscope. The only practical problem which you will face is how to shift. Is shifting a complicated issue from microscope to endoscope and from endoscope to microscope. Now, first we'll see the video of how in a single setup in an OT, you are going to shift the microscope to endoscope and microscope to endoscope, vice versa. Okay, here we go to the share screen. So this is the OT setup which I have. This is the microscope, and you can see this is the C mount and the coupler. Okay, so that is the important point. So this is the common head which you are required if you want to practice microscopic and endoscopic ear surgery. So if you have this adapter, it is very simple to switch from. Always I have a microscope in my OT. And this is how we connect the camera head to the microscope. And then now we can see the image in the monitor. So this is how you set up. You can see the position of the patient, position of the camera, position of the monitor. Very simple. Always have this double setup in your OT. It is always better. And now when you want to shift on to the endoscope, just push the microscope to the right side. For the same patient, you can just switch on to the endoscope. That's all, right? So this is while you're operating, it's very simple. See, the patient initially operated with the microscope, and then when I want to switch over to the endoscope, just push the microscope to that side. It is very easy, right? It is not cumbersome, very casual. You be prepared. Just push the microscope. And then the same thing. Okay, very simple. You can always use your endoscope along with the microscope in a synchronizing manner. Do I use this setup for all my cases? Never. So majority of tympanoplasties, I do it single-handed. Okay, so when I require extended drilling, I go in for a combined approach, right? So we'll see one interesting video and see whether you're convinced or not. This is a setup which we have.
We can't hear the audio, Vetri.
Can't hear the audio. Okay. Now?
No.
Audio?
No, from the video, there is no audio.
Okay, now I'll talk, no problem.
You talk.
So this is the first case. This patient had a ear discharge for the past 5 years, which was foul smelling. Pure term average was 50 decibel hearing loss. Ear discharge is independent. The CT scan was done. Disease was revealed in the attic, which was extending posteriorly towards the mastoid air cell system. It was extensive. And initially the case was started endoscopic, and then the tympanomeatal flap was elevated. The long process of incus was necrosed, and then the posterior tympanic sinus proctor was involved, and then it was extending superiorly through the posterior isthmus tympanici towards the adductus and then to the mastoid antrum. And then I planned for since the disease was extensive and it had a cellular pattern and it was involving the tip cells, so I planned in for a post-oral mastectomy and later reconstruction. And then now we'll go to the CT scan of the same patient. So this is the CT scan showing disease in the left side. You can see the extensive pneumatization, and you can see we're not able to differentiate it is exactly cholesteatoma or mucosal edema, and that's why we didn't plan for initially it started with an endoscopic, and then going along with the findings, since it was extensive, and then I planned in for an endoscopic approach, microscopic approach. So this is the endoscopic picture. The left ear, this is superior, inferior, anterior, posterior. So you can see the tympanomeatal flap is elevated. This is the posterior canal wall and this is the anterior canal wall, superior, inferior. The tympanomeatal flap is elevated inferiorly. And you can see how beautifully the annulus is being lifted. And you can see the attic granulation, which was removed and it was sent for histopathological examination. And see, this is the attic defect involving the Korsak space, handle of malleus, lateral process of malleus. You can see the tympanic membrane is intact. The tympanomeatal flap is elevated inferiorly. And now we can see the vision of the long process of incus. See, this looks like a fracture or the due to disease, right? And you can see the cholesteatoma sac. This is not due to iatrogenic, and this is real erosion due to disease. Patient had 50 dB hearing loss. The posterior curating is started from the posterior tympanic spine. So left side curating is easier a bit when compared to the right side. Is my audio okay, Janaki?
Yes, fine.
It's okay, but you don't have audio in the video, no?
No, I have cut the, because since the video sound is not coming, I have cut the computer sound.
Carry on.
And you can see the incus is being removed. You can see the erosion of the long process of incus. And now we can see the cholesteatoma stack along with the granulation in the posterior part of the retrotympanum. %99 of my steps are the steps of Dr. Janaki Ram. The neck of malleus is clipped and the head of malleus is removed, showing disease in the anterior epitympanic recess. And the disease process in the anterior epitympanic recess, the attic, and in the region of the adytus is removed. These specimens are removed and sent for. And once I inserted my endoscope inside, I could see the disease extending posteriorly with the pneumatizations and with the pseudo or with the foot-like processes. So the disease was extensive, and I have seen cases initially when I have done a complete endoscopic procedure for extensive pneumatized process, I have faced some failures. So I opt to, in extensive cases, when the disease is involving the tip cells and having the false foots, and I opt for a combined approach. Now, within seconds, you can convert it into a post-oral approach. An inferiorly based skin flap is placed. And this is the fast-forward drilling. So the drilling, you be conservative. You don't do an extensive drilling. Be watchful. Do an inside out, and follow the disease. When the disease is limited to the attic and it is just sitting on the adytus, then endoscope would be an ideal tool. But still, we can do an endoscopic procedure in extensive mastoid, but I feel it is time consuming and you feel fatigue. Moreover, the failure rates in extensive pneumatized mastoid disease is more. You can say I've done a wonderful clearance, but still when you follow up, when you do plenty of cases, you know what is happening. So you can see the extensive disease involving the attic, adytus, and the antrum. We can see the cholesteatoma flakes. When you have a good exposure, then everything is very easy. You see the sclerosed bone, right? Sclerosed bone has to be removed and the polishing has to be done. If necessary polishing of the sclerosed bone is not done, it will lead on to failure. So that is why I never, in extensive cases, I never opt for an endoscope. You can see the disease clearance. An adrenal soap cotton ball is used for dissection. And the flakes are sent for histopathological examination. Disease clearance along the tegment plate. See, I have not made the cavity very big. Now having an endoscopic view and using endoscope to clear the disease. Once you have a very good exposure, the chances of injuring a telescope is very less. You can do a beautiful dissection once you have a wide exposure, and chances for injury to the scope is less. Again, switching back to microscope, clearing on the disease along the, you can see the retrofacial cells extending onto the sinus tympani. Facial ridge is gradually reduced. And you can see how beautifully the disease is dissected over the lateral semicellular canal. This is lying medial to the lateral semicellular canal. You can see the how it is cellular and it is extending inside the air cells. When you want to work with an endoscope at that site, it's very difficult. See, the lateral semicellular canal will definitely hide your view. Clearing the tegment plate. See how much of drilling work is required. So in such cases, I prefer a combination of microscope and endoscope. Lower it out the facial ridge. And now after complete disease clearance, the disease so lying anterior to the stapes footplate is being removed. And now we can see the confirmation of the disease clearance with the endoscope. You can see the posterior tympanic sinus of Proctor, the sinus tympani, the hypotympanum, the subpyramidal sinus, all free of disease. Removing the healthy mucosa. Final polishing. So this amount of disease clearance is essential for such extensive cases, or else definitely recurrence will happen. And the endoscopic view for confirmation and to confirm the ventilatory pathways. Here you have the anterior tensor fold patent. You can see the complete disease clearance in the attic, additus, antrum, mastoid cell, tip cells, sinus tympani, retrofacial cells. And now I've used the cartilage for reconstruction. The stapes was mobile. And now that piece of cartilage was placed over the head of stapes, and then it is supported on all sides so that it is not slipping into the middle ear. So the contact was secured using conical cartilage, and then it was stabilized. A small piece was placed on the attic. Temporalis fascia harvested was placed. To see the simple videos of endoscopic mastectomy, you can go through my YouTube channel, South Zone ENT 12,002. You have complete endoscopic management. And then the graft is placed. A small myotoplasty was done, and you can see the post-op. No, you will not believe. See, this is the post-op. This was the cartilage piece was kept here, second piece, third piece, and one place in the attic, right? You can see how the epithelialization manner without any obliteration can make a scaffold like a what to say, a complete reconstruction. Okay, so always all cases does not require reconstruction, right? So see this case. This is post-op 4 months. PTA was 25 dB hearing loss, and this patient was able to swim. So you will not believe that a canal wall down procedure was done for this case, because the way you do the myotoplasty and the way you place the graft, this will completely close, right? So I'll show you 10 to 15 cases in my next lecture, if possible, on the fate of unobliterated mastoid. So this is case number 1. So this is the post-op. And now coming on to the next case. So this is microscope and endoscope assisted ear surgery. CSOM is squamous cell disease. Modified radical mastectomy with tympanoplasty. Incus stapes superstructure was absent. The left side. So this case, patient had CSOM, this is a 20-year-old female. Here the postural approach was done. There is cholesteatoma involving the middle ear, attic, additus, antrum. A reconstruction was used using a conical cartilage, and the posterior superior drilling was done. There was extensive disease in the sinus tympani, posterior spinal tympus, additus, antrum, and the anterior recess. Sir, here you can see the postural approach. Initially, we started with the postural approach. And once we elevated the tympanomeatal flap, you can see the footplate very clearly. There was no stapes. And then the posterior superior quadrant was drilled. A C-shaped drilling was done. Inside out canal mastoidectomy was done. And now we can see again the extensive disease with the sclerosed mastoid. You can see the cholesteatoma flakes in the region of the additus. The bridge was removed. Whereas incus was absent in this case, no remnants of incus. You can see the disease involving the anterior epitympanic recess. The disease is removed from the mastoid antrum, and gradually the drilling is extended. So again, I want to say that this type of cholesteatoma, it is very difficult to manage with the endoscope in my hands. It takes time. It makes you strain, but you can work. You can see the chunk of disease in the mastoid, which was elevated. And you can see how it is extending towards the posterior isthmus region. The flakes were removed. The disease was completely cleared. Disease from the anterior epitympanic recess was cleared. And now the endoscopic view show that the remnants from the disease clearance from the anterior epitympanic recess, direct control over that region and ensure the complete disease clearance. The tensor tympani tendon was cut and the mantle of Meles rotated anteriorly to visualize the disease in the region of the eustachian tube and in the supratubular recess. The disease is removed, and under endoscopic guidance, the facial ridge was reduced. The disease confirmation in the sinus tympani. Final polishing of the mastoid antrum. Reconstruction. I have placed a vertical strut and supported by the conical cartilage. You can see the disease clearance in the region of the foot plate. This is microscopic view, and still more better clearance with the endoscope. This is gel form dissection. And you can see the endoscopic picture of disease confirmation over the foot plate and disease clearance. You can also work with the endoscope at that region. These are delicate zones which can be better worked with the endoscope. A concave cartilage is used for reconstruction, initially for support and to prevent the vertical strut falling anteriorly. A support was given in the anterior part and a vertical strut was placed exactly over the foot plate. and it was well secured by other piece of cartilage circumferentially. So you can see all around the completely the vertical stud, but the vertical stud will be the highest point where the graft will sit. The vertical stud will be the highest point where the graft will sit. And this is the reconstruction. Coming on to the next video. So again, this is a case of external canal cholesteatoma. This can also be managed alone with an endoscope, but since it required a bit of drilling, I switched over to a microscope. So this is a case of cholesteatoma of the external auditory canal. We'll just go through the CT scan. This is cholesteatoma of the external auditory canal. We'll go to the CT scan. This is the left side. You can see a well-limitized mastoid. This is anterior. This is posterior petrous apex. From above, we are coming down. Superior cervical canal. Then coming lower, below, from above. We can see there is no disease in the mastoidal system at that point superiorly. And when we go inferiorly, this is the additus antrum. And you can see the defect in the posterior canal wall. You can see the defect in the posterior canal wall. This is the intact tympanic membrane. And you can see the disease in the inferior part of the mastoidal system. We don't know whether this is mucosal edema or it is cholesteatoma. So you can see such a broad defect in the posterior canal wall. So this is the middle ear. And this is now the endoscopic vision of the external. This is anterior, this is posterior. We can see the defect in the posterior canal wall, which is extending onto the mastoid system. The tympanic membrane is seen, but we don't know whether it looks like present, but we don't know the status of the middle ear in this picture. A postural approach is done. There are cases where you can manage comfortably with an endoscope, and the difference of opinion. You can manage with an endoscope, but I found in this case I require the time factor. You can see the cholesteatoma which will be removed. You can see the glue. Just a minimal drilling. And now You can see the edges are being smoothened. Always you don't want to have ups and downs in your cavity. That will prevent the healing process. Still, you can see it is extending inferiorly. Sometimes when it is extending inferiorly, you have to be very careful about the dehiscent bone, and if the jugular bulb may be dehiscent at that point inferiorly in the depth. You can see the disease clearance from the mastoid tip. And now if I want to visualize in the deeper part, I just put my endoscope and do the drilling work and the disease clearance for the final disease clearance with the endoscope. I just, since in this case the tip and mirror thickened and the CT was done 1 month back, I just wanted to find out the condition of the drainage pathway. So I will be shortly elevating the tympanomeatal flap, and then I irrigate through the mastoid antrum and see whether it is coming through the isthmus, additus. I am elevating this because the CT scan was done earlier. So to rule the disease in the middle ear at the time of surgery, I just elevated the tympanomeatal flap and to check the patency of the additus. A few drilling work is done to remove the granulations in the mastoid arterial system, and then it was irrigated, and the cross irrigation was done, which revealed the patent drainage. Without confirming this, if you proceed on to the obliteration of the cavity, and then chances of recurrence and disease process will continue. A temporal dysphagia was harvested and then it was placed under a graft. Just to give a support. A conical cartilage was harvested and placed, used to close the defect. And this is the post-op. You can see how beautifully the tympanic movement is now, and now we can see in the floor the defect is completely closed by the conical cartilage, and there is no, the patient is under follow-up, and you can see how beautifully it has been obliterated. So the case is now still being followed. And now after seeing these videos, I think basically understand a few things. Certain things are very easy with endoscope alone, that is single-handed endoscopic surgery. And some cases, there are exceptions where you feel that if I would have had my microscope along with me, it would have been easy. In such cases, you go ahead with this MAIS or microscope and endoscopic assisted ear surgery. There are no problem, right? There is no harm in saying that I use only microscope, I use only endoscope. There is nothing like that. You are a surgeon, you select your options, you feel your success, do your study and follow your own dictums. Thanks for watching. Janki?
Yeah, I'm there. So that was a really extraordinary talk, Dr. Vetrivel. I really appreciate it. I want to tell something about Vetrivel. I habit of going to his clinic once in a way. And his uniqueness is that he has got records for many, many years. And actually, he records both endoscopically and also records his post-op 3 months, 6 months, 1 year, both audiogram wise and also the picture, endoscopic picture wise. He's got thousands and thousands of records. Actually, that actually is worth. He can actually write a book or publish it like a very big year manual. Really appreciate you for that, Vetrivel. I really, really appreciate you.
Thank you, boss.
This kind of documentation, I'm telling it out of my heart. Not that I want to praise you. It is showing on. See how you showed all the post-op. He's got a serial recordings. Okay, now coming to questions. Can you take some questions, Dr.
Yeah,
Vetrivel?
sure.
Okay, Dr. Hitesh Patel from Morbi. For support of the vertical strut, exactly where you put the cartilage in the middle ear or promontory, didn't understand exactly, sir. Please explain.
Actually, a very nice question. So once you're going for the ossicular reconstruction, the only assembly which whether the other points are in contact with the promontory or not, the most important thing is the direct vertical strut which is sitting on the foot plate. That is one contact with the neotympanum. So that is the main contact. So one thing I keep in the promontory, that is just exactly anterior to the, it sits over the promontory. Okay, it sits over the promontory.
Okay, that's a great answer. Again, Dr. Majumdar, Professor Majumdar sir is watching you. And
sir, good evening, sir. You are my great teacher, sir.
Yeah,
how are you, sir?
You give a lot of mean Colombo to him, huh? Okay.
Sir, very unforgettable person. I am a great fan of Dr. Majmudar. We want to be like heroic like Dr. Majmudar, but I think it will again take plenty of years to achieve his heights.
Okay. Now we have one great gentleman. Before I pass on the next question, I just want to acknowledge one important thing. Dr. Anthony, Professor Anthony actually has asked his postgraduate to get a microscopic video, and the microscope has the postgraduate has downloaded a video of Dr. Minesh Jovikar. So just wanted to acknowledge that, but it is without his knowledge that he has used it. He even doesn't know that it is Dr. Minesh Jovikar's video. But Dr. Minesh Jovikar is a fantastic ear surgeon. His videos all around and being quoted as standard examples, you know, a wonderful ear surgeon. So Dr. Vetrivel, we have a question from Dr. Majumdar, sir. Theoretically and scientifically, you need not remove acquired cholestoma like squamous cell cancer, as it is a confusion of reparative process. Good aeration from eustachian tube would restore first law of Bernoulli, and dead squamous epithelium would be gobbled up by macrophages and other immune cells. Proper physiological aeration, mucosa or mastoid and middle ear would help you. Yeah, so he's just made a comment, not a question. So thank you, Dr. Majumdar sir, for watching all the three of them. Actually, we have one guest with us. Dr. Prakash Munka sir is here. Can you just unmute Dr. Prakash Munka sir? Dr. Prakash Munka ji, are you there?
Yeah. So Dr. Minish has
I'm
also
very
joined.
much there.
Yeah, Dr. Munka, can you show yourself and you know, if possible, comment or ask questions if you because you are like a father figure now in webinar. You are the father of webinars now. You are everywhere. You are everywhere. Believe me, I have gone to what is called the WAS, the level of WAS. WAS means webinar aversion syndrome. I have developed that, and now you are the person who is having webinar affection syndrome. So I am against your fault. Now I just want to, oh my God, leave me. I have come to that level. And you say, yes, I want to be in all the webinars. Great, great going, Dr. Prakash ji. Actually, we are being watched by more than 700 people all across the world, and that's a great thing. All the three speakers have got. See, a normal webinar has around a normal conference has maybe 100 people. For that, we'll have to, you know, pull in a lot of people, and you see the webinars are attracting so much of crowd. Dr. Prakash Munka, can you unmute and talk, please?
Sir, Dr. Minish has also joined.
Yes, first Dr. Munka and then Dr. Manish. Dr. Prakash ji, are you there? Okay, if he's not there, we'll ask Dr. Minish Juvikar. So maybe he can ask a few questions or comments or whatever. Dr. Minish, are you there? Can you?
Yeah, can you hear me?
Yeah, absolutely.
Yes,
We welcome you to this panel of our classmates. We four are very close friends. Very
I know.
close friends. Yeah, please carry on, please.
Yeah, firstly, thank you for including me, Dr. Janki Ram. What I realized, I'm a very good analyst, that you are also one of the reasons why all your panelists have been really sharp, because you have been actually after them in many ways, and they kept on telling that Dr. Jankiram has been one of the guys who's been after us and things like this. That's a very good gesture, and I appreciate your things. Now, it's a fantastic session, and I felt that it's very good to know, what people are doing all over the place. What I liked and loved about Vetrivel's lecture is that, he is not really talking about only endoscopy. The first important part is the patient. The patient is important, and giving him is something important. Now, what I would like to know is about cavity obliteration. So you're doing a bad mastoid, and Vetri showed a lot of cholesterol in the sinus tympani, a lot of areas. So do you really keep an endoscope as an important tool when it comes to giving an obliteration cavity to the patient? That's what I want the panelists, the speakers to let me know.
Okay, Vetri, you want to take that question?
Yeah. Minesh, usually cavity obliteration, if it's very extensive, then the outer wall is completely, the lateral wall is completely removed, then definitely we have to do an obliteration. I usually do an obliteration along with an endoscope. I use a temporalis fascia rotation flap and place it inside, or place or Pavlov's flap or post-oral, the flap, put it in the cavity and then do the obliteration. But some cases I've seen when a small meatoplasty is done, and then when the facial ridge is not fully reduced, okay, when the facial ridge is not fully reduced, it has got a height, the complete disease clearance is there in the sinus tympani adductus and antrum, and 100% the disease clearance in the adductus and the mastoid air cell system. And then the simple graft, you can keep a cartilage, concave cartilage region of the adductus and place a graft. Or else, even if you don't place the graft at that point, that temporalis fascia grows well at that point, and then the normal air lifts the part of the adductus, so it remains ventilated. So whatever you do that.
What I'm trying to ask Vetri and Dr. Ahilya, who's also a very good friend, is that, with due permission from Dr. Jankiram, I want to ask this question: is that what is the role of an endoscope in ear surgery? I'm not against an endoscope, mind me, but is it just to know the hidden areas? It is just to know a better result? Or is it a future in something which you're talking about, otology surgery? That's what I want to know.
The most important thing is hidden areas. Disease clearance in the hidden areas. Number one, the priority is the endoscope, and limited drilling, so that you keep a small cavity to prevent cavity problem. Endoscope is the best tool.
Okay, can we have the answers from the other panelists as well? Because we have one junior Robert Vincent of India, who is absolutely microscopic ear surgeon versus, junior Joe Flavo, or maybe even the big, I don't know the big names in endoscopy, Dr. Anthony is here. Now we'll have a little war, and we'll just enjoy the war between the two. Spicy war. Okay, Ahilasamy is there. He is the guy who actually put one last video showing that I'm he called the microscopic surgeon. Sorry to tell, I'm also a microscopic surgeon. I felt that I have been kicked out like football. Where is Dr. Aguila? Pull him out and make him answer the question. Where is Aguila? Hello, you kicked us out.
Yeah. I can see you.
I can't see you.
I didn't say. You read the page number 1055 of not proud. Page number 1055. Endoscope has replaced microscope.
So what is your see?
No.
The Quran, the Bible, the Bhagavad Gita of END is telling. Not I am telling.
No.
Page number 1055.
Minesh, sorry that I didn't know that is your video. It's a fantastic video. I wanted a fantastic video. One of my postgraduate gave this video. I should have acknowledged you. Sorry. And thank you very much for that video. That video was showed only to show that microscopic surgeons also do it with only one hand, nothing else. Sorry for...
No, Dr. Anthony, you're a senior doctor. So there is no apology, and of course that's fine. Don't worry about it. Don't worry about it. You're a very senior colleague.
Rather Manish, I will say, Prakash Munka here, I will say it's a pleasure when Anthony shares your video.
Yeah.
Only thing was that he was not knowing, otherwise the time.
That's fine. That's fine. That's absolutely. Sir,
Let's get down to the question of now Ahilasamy is kicking us because of Scott Brown.
I mean, you can't put page 1055 saying that says it. I mean, Ahilasamy has.
He must have.
Hello, Dr. Prakash.
Minesh.
Yeah. I'm here, but my video is not coming, and internet is a bit unstable.
Okay.
About Vetri.
So he is a very clever guy. He took a middle.
I am very happy to see you after a long time. I know, but as far as I know him,
See that.
this person is starting from how soon he switched the gear to the endoscopic. One question which I always haunted, I am basically a microscopic surgeon till my retirement, but then
Hello.
and tried to do with that. I asked Mubarak, can you go through a post-oral incision in a very positive or negative way? Because through the ear canal, with one
Net is poor.
telescope, you get, I mean, always struggling for it.
Hello.
Dr. Can I put in a comment?
Opening my post-oral incision and getting Janki's forehand technique, holding somebody else to the endoscope and do the surgery. So this and today it has symbolized a combination. If you go through post-oral incision to begin with.
Okay, now let us. His net is poor. Dr. Anthony wanted to tell something about that comment of Dr. Minesh.
Yeah, I was in Dr. Minish's workshop where Professor Mohan Kamachan was operating on a glomus video. Remember? Somebody asked me, can you do this the endoscope? I just casually said yes, I have done enough. That question was asked to Mohan Kameshwaran. Straight, sir, they said that Anthony said he can do it with an endoscope. Sir told, yeah, few people can do like with an endoscope. That doesn't mean everybody will. The same way, few people that in my lecture itself I told, this is only for the people who are learning to select which one you want. You can not for the surgeons who can operate very well with a microscope like Janaki Ram and I mean, there are people they do very good work with a microscope. They can continue doing it, but we don't know what they will select. It's like two things served on platters to the young otologists. They will learn both. Whichever taste they like, they will take it. And the world feels in future, they might say, this is simple. In a competitive world, you got to do something different, as Ahilasamy said. then only they will see. Everybody was operating with a microscope. The person who operates with an endoscope says, I can do this, that with an endoscope or things like that. But that doesn't mean that's always true. The tool is not important, but how much good work you do is what is very important. So a person who give a very good work with a endoscope need not claim that only endoscope gives that very good result. Maybe in his hands that endoscope gives very good results. But the people who have been doing the endoscope for a long time, they know you can give the same result or better results with the microscope with his hands.
But I'll tell you one incident, Dr. Anthony. See, any innovation is accepted by the world very fast. This is something. Of course, there's a stage where there is a lot of objection, repulsion, and then the acceptance is very fast, provided the teachers are classy.
Janagi, as I mentioned, how that all truths are being accepted in three stages.
Exactly, three phases.
And, I go with
I was called by Professor Castelnuovo over phone. He said, Janikram, you're doing a masterclass Milano on skull-based surgery. Can you do a 1 hour full lecture on endoscopic ear surgery? He asked me this. I was surprised. I said, you're including endoscopic ear surgery into Milano masterclass?
Yeah.
He said, yes. And when I went to America, to the American Congress, most of the sessions were endoscopic ear surgery and all the halls were full. And all the microscopic ear surgeons, the hall were half empty or even maybe 4 or 5 people. So I think, one thing is the level of interest in endoscopic ear surgery is terrifically taking out. And when we show it with the microscope, the quality of the surgery is a little, at least to demonstrate, it is not as impressive as an endoscopic ear surgery demonstration. Of course, endoscope has got that resolution and things like that. So, and today I saw Dr. Joe showing a robotic endoscopic ear surgery. So people are going crazy after new innovations. Of course, it's...
with this point, Dr. Jankiran, can I put in a small comment with your permission?
Yeah. Please, you don't have to ask my permission. You're a panelist. You're a moderator now, please.
See, I tell you something very interesting. I've been to this American Academy as well. Now, the problem or the scenario is that the evidence of cholestoma, when it comes to countries like India, Bangladesh, Nepal, is different than when it comes to the US. There they have very limited cholestoma, very small pockets, which can be covered with an endoscope. Here we are in a different boat, and we are going to be in that boat for some point of time. So the scenario is that, of course, endoscope is not bad. Now I can just share 2 views with you. In my first fellowship, I went to Professor Hildmann from Germany, Bochum University. And Hildmann was a fantastic otologist, but very aggressive guy. The Germans are like 6'4" and aggressive people. So I asked him that you would like an endoscope or an otoscope. He says, the way to the car is not important. The car you drive is important. So with that, he went away. So I realized, I analyzed the whole night what he meant. Then I asked Professor Robert Vincent, who is a much more softer guy, a much more delicate Frenchman, typical Frenchman they would have, is that would like to do an endoscopic stapes. So his result was, well, it looks good, but all the ladies that look good in France are not really that beautiful when you see them in actual on television. so that's the way, the Frenchmen take it. So he says, I have so many French actresses who look so beautiful, but when I see them in reality, it's difficult.
Yeah. Reality.
So what do you mean by reality, my dear?
So the only thing what Vincent told me is that endoscope surgeons are a lot in France, and it's good. He is not. The important point is he's not against endoscopy. He feels it's a good tool. Anything that helps the patient is good. So that is the final line for all of us. We are all together. So the final line is anything that helps the patient is very good. That's very important. But the problem is that you don't neglect something else which can benefit the patient. So if you have maybe a bad revision stapes in which you can't do an endoscope, you don't have to keep your ego together to say that, okay, I will use only the endoscope. The patient is most important. So all these persons like, Dr. Anthony, Ahilya, Vetrivel, who are doing endoscope are far superior than what I'm doing in endoscope. I'm sure of it. But the thing is that if the patient demands something, the patient is most important. And someone like you, Dr. Jankiram, who is holding.
I have a comment, Dr. Minish. Yesterday, I had a panel on cavernous sinus.
I know. I was there for some time. Yeah.
I was operating endoscopic, and Dr. Cherian came in and said, we can do it, equally well, if not better, microscopic. So from outside. So he was talking about a scar surgery. I was talking about a no scar surgery. But the most important thing here is only the expertise of the surgeon. If you have a patient going to either Ahilasamy or maybe Anthony doing a stapes, in his hands the results might be good. But the same if a beginner is going to do with an endoscope, he's got a huge learning curve where his results are poor. So if he comes to Dr. Minish for a stapes, of course, Minish would not shift from his comfort zone of microscopic to endoscopic. And that's where, we have surgeons like Dr. Minish who are absolutely incredible with the microscope because you're so used to that and technically very sound. And there are people like Dr. Vetrivel who are used to both endoscopic and microscopic. So there are a very, spectrum of surgeons. And I think it's ultimately your expertise which should dictate. And if you are able to manage a glomus with the endoscope, well, why not? I mean, there is no point where only thing is that there should not be any complication. As you say, ultimately the patient's result and, a functional surgery should be the goal. So,
and there are people like Dr. Jankiram who are doing fantastic ear surgery and maybe not advocating it on internet. So when a patient like from me tells me he wants to go to Chennai, I'm not worried about Vetrivel or Ahilya, I'm worried about Jankiram more, because he knows everything.
Dinesh, we both of us presented in Mahabalipuram sometime 1 year back.
Yeah.
He was talking on pituitary surgeries and I was talking on stapes. Whatever Janagram told about endoscopic pituitary surgery compared with that of the microscopic surgery, what all advantages he told, he was contradicting me when I talked about the endoscopic stapedectomy. The same point, all the same points. It's only our training and we advocate what we profess. But that doesn't mean that's true.
See, right? What's very important, is that the patient is most important. Now, what I want to ask all of you all, because there are many people listening to this, if you have a complication, like yesterday, I was opening a stapes and I had a very bad gusher. If you have a complication, would you really think about, do you keep a microscope standby behind you to really think, okay, this is important, the endoscope is not important for me. Now, yes.
Means, if it happens to me, I can't go to a microscope because I am trained all the way in endoscope. So if I am doing with a microscope, I can do a bad job than with an endoscope.
What about Dr. Vetrivel? Where is he? Dr. Vetrivel, is he gone?
Yeah. See, Minesh, I'm telling you, we don't know which case. I told you, routine tympanoplasties, I feel endoscope is the best. Single-handed endoscope usually. Routine, no much of drilling work, just elevating minimal disease clearance the middle ear or attic or the adductus region and come out without, you can do a bit of curating, but if there is extensive disease process, when the patient is having osteotic bone in the mastoid.
I'm talking about a complication, for example, like in a stapes surgery. Would you actually think about going to a microscope in the whole scenario?
Maybe rarity.
Andrew will answer.
Very rarely.
Meaning, I will take the question. I had very, very bad gushers, which was managed with the endoscope. But I'm a real amphibian because I got trained with a microscope and still I am in Madras Medical College and I use good microscope, very good microscope, all latest microscope. Till we operate, we do a cochlear implants only with the microscope.
So I'm so lucky, Dr. Jankiram, none of these guys are in Mumbai. I'm so happy. I'm jobless.
But
Manish, can I add in, Dr. Janki, with your permission, I can add on one point.
Please, sir. You're the boss.
Yeah, as you used to say, the fool behind the tool is more important. It is not the tool that is more important. Basically, Manish is more used to microscope. Let him have his pleasure, his the share of the glory and the goodwill to the patient. And like there is if somebody who has taught from beginning in the endoscopic, he will be more comfortable. As Ahila said, if he goes microscope, he may not do a fantastic job. But if you are trained in both,
So, Dr. Janki, I want to ask you a question with your permission.
Vetrivel said, if more drilling, more extensive work, I combined the both. So probably, in my opinion,
Yeah, his voice is gone. Yeah, Dr. Manish, you wanted to ask something, please.
Yeah, I wanted to ask you, how many times have you actually used an endoscope in your ear surgery? You're doing a lot of ear surgery, I know. So do you use an endoscope sometimes? I mean, you do a lot of ear surgery sometimes, and most of the time your OT starts with ear surgery.
No, today I did, I think, 9 ear surgeries.
I know. I spy on you.
No, the thing is that, you see, it depends on the level of comfort. I tried to use the endoscope. The thing is that, you see, when I used my endoscope inside the nose, I had a little problem with the depth perception for a long time when I wanted to do my basilar versus the PCOM versus the peduncular fossa versus the mammillary body versus the pineal body. These are all very delicate structures. And so I had a long learning curve. But so I had to persist on it, and I had to say, yes, I can't do it with the microscope. I have to do it with the endoscope, and I had to persist on that. But having attained the level of comfort in the microscope, I tried using endoscope because, now if you are a microscopic surgeon, you are not popular. I will tell you, around the world, you cannot gain popularity saying I'm a microscopic ear surgeon, because everybody is so good in microscopic. Yeah, even the junior most postgraduate first year BLO can do a fantastic mastoid with a microscope. But to do an endoscopic ear surgery and to outshine others now is simply
The
difficult.
challenge.
It's simply difficult, and I tried it 3 or 4 times, and I just couldn't go through that learning curve. The reason was because it was not a do or die situation. I had my Pentro with me. When I put my Pentro, wow! To me, it's like a Mercedes. I have to ride on a Maruti for a long time to come to the Mercedes. But these are guys who started with a Maruti and said, I don't have anything else other than the Maruti, and now they have gone to the Mercedes level. So they cannot now, the microscope has become a Maruti for them. They cannot drive it. So these are the guys we are talking about who have already achieved the level of expertise after going through a lot of bicycling and, scooter driving and then Maruti and then going to Mercedes. But we have the Mercedes with us. We don't want to go through that, the learning curve of going through a cycle. Why? We are already getting...
Let me put this slightly differently. Okay, I mean, I know you're the boss. Maybe slightly differently. I know you like that. But now there are about, say, 300 young ENT surgeons watching this. Okay, now they have watched me, they have watched you, they have watched...
Mini 700.
700, okay, they have all watched it, okay. So what is the take-home message, okay, honest take-home message, Dr. Janki Ram, I mean...
the honest take-home message is
for everyone. Now, there are guys, I will tell you, there are guys who use the endoscope because they cannot invest in a microscope. Okay, that's the reality. In Maharashtra, one microscope costs 3 lakhs, and endoscope can do both the purposes. So they start with an endoscope because there are overhand expenses and things like this. So now, considering that you're the boss and you have fantastic panelists here, so what take-home message would you give to all these people? I mean, would you use a microscope, an endoscope? What's the take-home message? And I would like you to talk along with all of them.
I'm going to treat all the people who are viewing like my children, my own son, my own daughter, and I will give you an unbiased opinion. I will tell them that you have to get trained in both, because I think if you're not trained in both, you will be missing that. See, the inventions and the new technology, we'll have to run with it. Now, The next generation is all about new inventions. We have consolidated on our past, like Harvey Cushing did a pituitary without a microscope. We had a microscope, we had the luxury. We are in a stage of saturation in our technology. But I always tell my son, you have to go in for the next innovation. And for that, you should have a solid background, like Professor Anthony had a solid background on microscope, and then he shifted on to endoscope. And so any postgraduate should not have only one in his kitty like Ahilasamy had, because he never did ear surgery before. He was never
8 years. 8 years I never touched the ear.
He never touched the ear.
Are you trying to say that you first use the microscope very well, get expertise in it, then go for the endoscope?
And if you want to become, popular in this world now, if you want to go to the next step in this world, then you have to go along the. I'm sure that the endoscopic ear surgery is in its infancy. Any field when it starts is it in infancy. So we will have a lot more, like for example, Agira's knife or whatever. You will have a lot more inventions in that. And if you're saying that no, I will not, and I close my eyes to that new inventions, then you will not be the trendy guy. So I became very trendy because I started endoscopic skull base. I started demonstrating cranios where the microscope was demonstrated. Now a surgeon can't become famous if I show an endoscopic cranio, or maybe tomorrow we're doing a meningioma of the cavernous sinus. If I show that endoscopic, people, I can blow them out. But you cannot do that with a microscope. It's the same. You apply that to the ear. If you show it with a microscope 20 years down the line, where a guy is going to do it with a lot more technologies in endoscopic ear, then you will be actually sedimented and left out. So you have to, if you want to get the name in the world, I mean, of course, for us, we have already, you're now almost on the peaking that level. I think you'll have, to me, to people like Dr. Minesh, who have already achieved their big goals, now trying to peak on that goal, I would definitely advocate you to continue on that and explore more possibilities. But for a junior, be very cautious and see that you run with your innovations and inventions, new inventions. If you don't do that, you're going to be left.
No, Dr. Janki, just to clarify, I have so many residents working, with me. Just to clarify, and many of them are online. I want to ask, just to clarify what you said. So what you're trying to say is that routinely, in all medical colleges, your surgery starts with microscope. Routinely everywhere.
No, not everywhere, because in Madras Medical College, every postgraduate comes out only knowing endoscopic ear surgery. They are
correct.
only in endoscopic ear surgery. To me, that is bad. To me, that is bad, because I think, see, for example, Anthony was a person I know. He does a fantastic micro ear surgery, but then he wanted to run with the inventions. Now, after crossing that, lot of hurdles come to this level of putting that stapes piston with an endoscope is not an easy job. He's done thousands of it, and that's why he's attained that level of expertise. I think to me, I think if I am a student in Madras Medical College, I would be I'll be revolting against my professor saying, sir, I want to do 2 cases of my microscope as well. I want to do 2 cases of endoscope as well. Then allow me to choose after my post-graduation as to where I want to go. Because, I don't know what Professor Anthony did, the same. But I didn't have that opportunity. So
but don't you think that when you go to a microscope, I'm not an advocate of a microscope or endoscope, anything. I do microscopy, that's fine. But don't you think that before actually going to an endoscopic, that's my conception, before you actually, like Dr. Anthony, very respected person, I love him a lot. But don't you think that before you go to endoscopic ear surgery, you actually have to have a good experience in microscope? And you can actually advertise and go further. But if you do only endoscopy, and I don't think it's a great idea.
No, Minesh, I think you are all mistaken. There are certain surgeries which can be done only with the microscope, like cochlear implant.
Correct.
Right? So the people got to learn both side by side.
Correct.
Why they select endoscopic ear surgery for tympanoplasties and grommet impressions and external canal surgery, that they are also doing endoscopy with the nose, where they don't do microscopic surgery with any other part. But still, till if I don't have an endoscope holder, I do my oropharyngeal surgeries like expansion sphinctoplasties and palatal advancements. All these things I do with the microscope only. So you got to learn microscopy and endoscopy side by side. Okay, but because their endoscopic nasal surgeries are more, their hands are well versed with the endoscopic ear surgery. They stick on to the endoscopic ear surgery for a middle ear as well as external ear thing. But he will be doing microscopic surgery also. Not everybody does the nobody can do a cortical mastectomy with an endoscope. Nobody can do a modified radical mastectomy when you want to do it canal wall down with the endoscope unless it is very to them, because that only we know that complications rates are extremely high, particularly to the tegmen and other areas with an endoscope. So we don't give that to the postgraduates. But what happens generally, all the people are usually a good endoscopic ear surgeon. But they also learn microscopic surgery, and because they don't open mastoid in all cases of tympanoplasty. We know that people, even for a dry operation, they just open mastoid, saying it's only a 5-minute job. Okay, but not everybody will accept. Not everybody is not universally accepted, because when there is absolutely no disease in the mastoid, why you want to open that?
Correct.
Right. So for that, when you want to do only a transcanal tympanoplasty, the people think middle ear and the external ear procedures are all easier with the endoscope.
I know. So accepting and agreeing.
I want finish. I want to finish.
Endoscope, all this, see, depends on what you're using. But I would like to quote the paper. See, for example, meringoplasty, you do the endoscope is easy. For me, with a microscope is also easy. So depends on your expertise. I just want to quote one important thing. You see, we had a study by Professor Kassam. Okay, and he does everything endoscopic, including brain surgery endoscopic. Okay. What he does, see, you said cochlear implant cannot be done with an endoscope. Cochlear implant is going to be done with an endoscope. Believe me, it's going to be there in near future. Okay, so this is going to be exoscopic surgery. So we're going to have people having exoscopes and operating, because now there is a study, you can refer to the paper, microscope, when you focus it on the external canal, you will not have a focus on the tympanic membrane and the foot plate. Okay, so you have a varying depth perception, whereas an endoscope gives a uniform depth perception. There's a study, there's a paper by Kassam, and they have done a lot of physics analysis on nanometer level studies on the depth perception with an endoscope versus the microscope. Microscope gives a magnification on a particular strata. If you increase the magnification, the depth perception reduces. Whereas an endoscope does not have that problem. So this is a very major.
But Dr. Jankiram, I accept and respect what you're saying. Now, if you're talking about the residents who are passing MS.
Yes. Answer one thing, my point. I started with the endoscope and everything, but before that I had lot of temple bone dissections. So around 10 years back, there was a scheme in Tamil Nadu, government scheme, where you have to do cortical mastectomy and mastoids with the post-oral incision and take picture and send it for the government scheme. Then only you get the money. So after doing,
is that scheme still on? I need the money. Is that scheme still on?
Now the scheme is not there. Because if you have the postal scar, then you have to take the photo of the postal scar, send, then only you get the money. So after doing endoscopic ear surgery, then I traveled all the way to Trichy, learned from Janigram to do cortical and good post-oral mastectomies, and then I tried. And to your point.
No, coming to the point, see, Minish is very clear. He wants to know his postgraduates, what should they do? Should they do microscopic, endoscopic?
They should learn both. They should learn both.
Dr. Jankiram, we
learn both.
don't want the wrong message at the end of this wonderful discussion.
Learn both.
It's very clear. The message is very clear, Dr. Minesh. It's a
Learn both.
There is no second question about this message.
Correct.
The message is that
Learn
you
both.
have to learn and microscopic ear surgery with your temple bones, do everything. But if you say a big no to the endoscopic ear surgery, then maybe you may not run with the future. Because the future, you never know what innovations are, because any infancy is going to grow. See, when I started endoscopic skull base, it was very primitive. Now it's very advanced. We have so many new equipments which are just flooding into the market. This is going to happen in endoscopic ear surgery, maybe a decade later or maybe 2 decades later. But when at that level, if you are not running with technology, you will be left out. So this is very clear. The message is for the postgraduates, start with micro ear and have your eyes open. Don't close your doors and say, all the big shots I have heard Professor Mario Sana saying, Professor Robert Vincent saying, everybody, I've seen so many micro ear surgeons saying, oh my God, this is bullshit. But I felt that they are all already old and they cannot learn the technology right now. And they will be left out when another 2 decades later, the juniors are going to take over and new inventions are going to come in endoscopic ear surgery. That is the time when they will feel that, oh my God, I missed the train. So this is something I will advise my son. I would say, learn your microscopic ear, but do not say a big no to the endoscopic ear just because you can't do it. Because the youngsters
one word to add. One word to add. Now people are doing a lot of inner ear surgery, small acoustics and small schwannomas through endoscope.
They are also using silent endoscope. Forget the endoscope. They are using silent endoscope.
That's how I threw the. I am not talking about that.
Another point.
I'm not talking about the complexity of the surgery. I'm not talking about the complexity of the surgery. I'm not talking about a person doing acoustic neuroma or something like that. I'm talking about the new innovations which are going to come inside the surgery. Please understand there's a lot of...
That's what I am telling.
So when new innovations come...
Dr. Jankiram, what you're saying is in a nutshell, to just convey to everybody, is that, the patient is most important. Microscope is something that has been used for 40 years. You cannot replace it, but do not ignore the importance of an endoscope. That is something that is the future. And if anything that benefits the patient, do not ignore it.
Another point is, Minesh, another point which I want to say is nowadays patients are, if you tell them ear surgery, they are asking the question whether you are doing endoscopic or microscopic.
Certainly. Whether I will get a scar or not, will you show my
they are asking,
or not?
it is up to their knowledge, but that awareness has come to the patient.
So I think in that discussion, with due respect to everybody, I think doctors are also to be blamed. There are few doctors who claim, just like Dr. Janki Ram, I will tell you, you had your discussions about increasing practice. Now, there are some doctors in that, who claim that I do scarless surgery, I do this, I do that. And that is what has evolved this discussion. But I think most important that if you talk about in Mumbai, you talk about your film stars, and I'm treating many of those guys, at the end of 5 years, they're more worried about a healed tympanic membrane perforation rather than a scar. So they're more worried about the result rather than anything else.
I will tell you a scenario. Imagine that you're going to give a completely healed tympanic membrane without a scar. Then would you say that, that is better? Or would you say that I will give you a healed tympanic membrane, but scar is okay. So which is better for you as a film star?
As a film star, obviously, without a scar is better.
So, you should know both.
You should know both. Yes.
That's why I put the picture of Amitabh Bachchan and everybody's picture I put.
That's why in Amitabh Bachchan they see him only from the front, not behind the ear.
Neymar has a undercut hair. That's why I put the picture of the Neymar.
Yeah, but it's a very good take-home message.
It's going to go on and on and on forever.
I know.
I think that to me, if I'm the moderator who has to summarize, I would definitely summarize saying that.
Janaki, one word before that. For a Muni's question, you please, when you have time, page number 1047 to 1055, Reason Edison Scott Brown. That explains very well in depth.
I'll tell you what, you don't have to convince me, okay? I am beyond that age of convincing, getting convinced.
Not you, I am telling, I mean.
If I feel that there's a distinct advantage of a particular instrument over a particular instrument, I'll be the first to absorb it. There is no doubt about it. So since I feel that I'm able to manage it, maybe one disadvantage is by a scar, I'm prepared to accept it. Fine. Okay. Leaving that apart, for the junior's sake, my conclusion would be, don't, because of people like me or Professor Juvekar or Mario or Vincent, don't say a big no to the endoscope, because I think you will then be left behind in the due course, maybe decades down the line. You never know how this is going to proceed. So, but microscope has got a sort of a, you know, when we started doing microscopic, there was a big rise, a steep, and now there's a little plateau, maybe a pentro or maybe a little better, there's a little plateau. But the endoscope is just starting. You never know where it's going to peak, like the corona, you never know where it's going to peak. It might peak in a level where you might be thinking, oh my God, I could have started earlier with an endoscope. So this is only the message. Yes, Dr. Anthony wanted to tell something.
Ninesh, my summarizing point for your question is, learn both side by side. Learn both side by side. Both of them will be useful in one.
And that is my topic, boss. My topic.
Your topic is not that. Your topic is not that. Everybody was in this point at different levels, right? But learn both side by side.
Absolutely, I fully agree with that.
Any given time, any one of this might be useful to you, or might not be useful also. But you should learn both.
Yeah, I think Manish, I agree with Anthony on this point, because we are used to microscopic, and we are you're very good. I am just a nose surgeon. I don't want to be a surgeon. But what I mean to say is, just because we don't do it, let us not take them off the opportunity of not doing it and just brand saying that this is bad, because there might be a little teacher bias. I agree. I tell my son as well, there will be a teacher bias. Don't do that. Be very open. Go to the best in the endoscopic here, like for example, Anthony or whoever, and then learn the nuances where you're going to have that extra. Like for example, one innovation can change your whole life, and everybody's going to talk about Ahila's knife or something like that throughout the career of your. That is exactly what you want, right? Apart from patient care being the absolute base on which you work on. So no compromise on patient care. What more do you build up on? This is finally going to be the answer to the question. So I think I thank, because it's actually a beautiful program. Time is just flying off. Thank you, my dear panelists. Thank you, Dr. Manish, for chipping in as a co-moderator. We are sorry about Dr. Prakash ji, who actually missed the voice. All the three speakers actually blew us out. Dr. Ahilasamy, Dr. Anthony, and Dr. Vetrivel. Thank you very much. Goodbye and good night.
Thank you.
Cheers to all of you.
Yes, thank you. Thank you.
Yes.
Good night.